Welcome, Brain and Spine Group, interdisciplinary approach to neurosurgical disease weekend webinar. And we're going to be reviewing some lessons learned from the Mayfield Clinic practice model. We've got a great assembly of faculty and staff from the Mayfield Clinic and sponsored by the Mayfield Education and Research Foundation to talk about what their experience has been in their private practice in a physician-owned model. We're going to be talking about a lot of things that are a little bit different from what our normal neurosurgical webinars cover. And I think that's really exciting. This is sort of our first, kind of going out into the business and the economics of neurosurgery. These are the kind of things that as medical students, we're not really hearing a lot about in our medical training or even for residents during residency. So without further ado, why don't we go ahead and get started. So this is just our brief schedule for the day. So we're going to start off with a review of the practice models and business by Dr. Ringer. So Dr. Ringer, if you want to advance the slide.
Sure.
Awesome. So it's my pleasure to introduce Dr. Andrew Ringer, who's the chairman of the board at Mayfield. He is a specialist in cerebrovascular and endovascular neurosurgery. He did his undergraduate training at Cornell University, followed by medical school at the University of Illinois in Chicago. He did an internship in general surgery, followed by residency in neurosurgery at the University of Cincinnati. And then he did a endovascular fellowship at the University of Buffalo with their phenomenal neurovascular team. So we're really excited to hear from Dr. Ringer again about this, pretty unique topic of practice models and business models within neurosurgery. So thanks for joining us, Dr. Ringer.
Yeah, my pleasure. So as you heard, my name's Andy Ringer. I'm currently serving as chair at the Mayfield Clinic, Mayfield Brain and Spine. And want to thank you guys for the opportunity to talk a little bit about how this practice is run and how it fits in the broader scheme of neurosurgery as a practice, in particular in the community at large. Some of this you may already know. This is sort of the timeline through which many of us passed in order to get where we are in practice in neurosurgery with after graduating medical school. Neurosurgery residency is typically 6 or 7 years in length, and many of us will then choose to do a fellowship. Some of us do a 2-year fellowship. That's what endovascular was back in the day. Now I think it's largely done in a single year because there's so much exposure to the endovascular during residency. And then some other fellowships are traditionally 1 year in complex spine, deformity correction, neuro-oncology, functional neurosurgery, things of that nature. So it can take 15, 16, sometimes 17 years after high school to get out into practice, which doesn't leave you a whole lot of time to actually build your practice before retirement, obviously, compared to other industries. So you have to think a little bit about where you are currently, where you want to go, and what kind of practice you think would fit you best. And you don't need to know that now. At this stage in your career, you're not going to have any idea what your practice model is going to be. Maybe by the time you get to graduation from a residency, you're going to have a much better idea of what you want to do. And at that point, you're prepared to kind of get that job. So what we're hoping to do is give you a little bit of information about what kind of jobs are out there, how those different practices are run, to give you an idea of what how you're going to spend that time between getting a job and retiring. So in general, there are a few primary models for medical practice, in particular within neurosurgery. A lot of neurosurgeons currently are hospital employed. They're hired by the hospital to put on salary often with some productivity bonus assigned to it. In these jobs, as you can see from the bullet points we put down below, very often your time at work, the duties that you have required of you, the time that you spend on call is all very much controlled by the contract you have with the hospital, which of course is related to the number of other neurosurgeons that they may also have on call and on contract as well. It also means, though, that your referral base is largely going to be based upon the health system or the physicians who serve that particular hospital. So you don't have to do a lot of work with the administration. You don't have to do a lot of program building. However, that also means that you're kind of under the control of the hospital. That you do more or less the practice that they want you to do. There are academic practices More typically, again, one is salaried. There may be some productivity bonus, but productivity is based not only on clinical productivity, but also on academic productivities. There's an expectation that you're going to be spending some time doing either research or publications or teaching. You'll be involved in administration from departmental affairs. So there's a fair amount of administrative work that goes on. And as a result, your practice tends to be a little bit more protected time because you have all these other things to do. Now, what we have is a private practice. Our practice is owned by the physicians. That means all business decisions ultimately come down to the physician owners. It's all based on what level of service you can provide to that community, and you have maximum flexibility with the amount of time that you want to spend there. So you can spend as little or as much time on your practice as you want, although understanding that you are somewhat beholden to your partners to help keep the business afloat. You have complete autonomy over the type of practice that you want, and that can change over time. Some of my partners started off thinking they were going to be doing one kind of practice. They ended up doing something a little bit differently because it just worked out better for them. And then you have to be able to partner with the hospitals and the health systems around you. It also means that because it's physician owned and we are not business people, we have to hire business people to run the business side of everything. And there are a couple of different ways that happens, which I'll show you here in a moment. There are such things as hybrid practices, what we call privatemic practices. These are physician-owned practices that work largely, if not sometimes exclusively, with a university for teaching and research. So you have a little bit of both worlds there. This slide says you could have the best of both worlds, although you could also argue you might have the worst of both worlds in that situation too. So these are all just different environments in which you might be able to work as a neurosurgeon. So these are the ones you see here on the left are the models that most of you will see during training. So if you go into residency and as a medical student do neurosurgery rotations, most often these are the people that you would see during your work. But that's not where all the neurosurgeons are. There's a group called NERVS, which is a collaborative group of executives who run neurosurgery practices that has run a few surveys over the years. And this is what the most recent survey showed was the distribution of most neurosurgeons across the country. Now, this is in the group, so that's a little bit of a selection bias. That's not necessarily what's always out there. Keep in mind the individual hospital employed physicians probably are higher in number than this. They just don't maybe participate in the group because they don't have the same vested interest. So a little bit about our specific group. Our group was started by our namesake, Frank Mayfield, in 1937. Yes, we are an 85-year-old practice. It was the first incorporated physician group in Ohio. Dr. Mayfield was an innovator. He helped to develop one of the first re-applicable aneurysm clips that was on the market, and that model, the design that he created, is still the one in use today. The Mayfield skull clamp, which helps to hold the patient's head stationary and in perfectly still position during surgery, was also developed by him and also is still used worldwide. So these are some real staples of neurosurgery. We also developed our own outpatient spine surgery center in 2007. And as a private group, we collaborate with virtually all of the health systems in our community. So the way it kind of works is like this. Again, we are our own private practice. We keep that practice working by focusing on a single specialty. Some private practices will be multi-specialty. In our case, we do have physical medicine rehabilitation. We have physical therapy. We have some other specialties that work with us, but we're largely to support neurosurgical practices. And then as a private practice, you may invest in ancillary services. I mentioned the surgery center as an example. Some places will have imaging centers or other types of procedural centers available that they might use. I mentioned again, that we use physical therapy. But as a private practice, since neurosurgery is largely a hospital-based subspecialty in many cases, you do have to partner with your regional hospitals. So you have to understand how you can provide a service to them to be of value to them so that that becomes value to the group as well. So a lot of things go into this for practice management. You see all these bullet points here: the organizational structure, how to intake patients and get them scheduled, how to operationalize your clinical activities, coding, billing, and collections. We, of course, use electronic medical records, so you have to have information technology. We, as a private practice, then make our own contracts with third-party payers like insurance companies and whatnot. Those are independent of what the hospitals have, so that's a different negotiation. And then, of course, because we're a fairly large practice, we are very, very data rich. So we keep track of our patients' outcomes very, very carefully. We actually employ people whose only job it is to follow those patients and find out, did anybody by chance get admitted to another hospital that we don't cover, so we wouldn't have otherwise known about their readmission? Did they have any other clinical problems that might have been related to our care? So we can keep track of those outcomes and be sure that they're accurate. And then, of course, all of that then rolls into risk management, rules and regulation. And then finally, that becomes part of our marketing, where we want to let everyone know that the high quality of care that we can provide to them. Now, neurosurgery private practices might be small. They could be as little as 1, 2, or 3 surgeons, up to 5, in which case, in this kind of a structure may be what you see. There are a couple of physician partners. They hire an office manager to help run sort of the business and the operations of the office. They hire people to be the frontline people of nurses, medical assistants, receptionists, and to do the billing. But a lot of the larger scale things like payroll, information technology, things like that are usually outsourced. You can find a business or a company that will do those services on a contractual basis for your practice. And that's probably less expensive and more efficient than hiring your own people to do that when you're this small of a practice. Now, on our side, on the other hand, we're a pretty large practice. So we have a board of directors that's made up of the owners, which we call the shareholders, and the non-owner physicians, which we call the non-shareholders, all of whom employ a chief executive officer. That CEO then oversees the vice presidents of the organization, which look into finances, operations, and strategy, which relates to future planning, looking at how medicine is going to change in the future. So all of those then functions like doing research, the physical therapy, the standard things that we talked about before, like IT, revenue cycle, which is the billing and coding, the onboarding of new employees, the running of the clinics, getting patients in and getting them scheduled, all that stuff, scheduling our surgeries with the hospitals, all that then is done by people who are in these different units of the business. So this runs more like a true corporation in this case than a smaller practice would be. So as you can see, a lot more overhead, a lot more people are necessary to make this operation run, but it makes it run very, very efficiently. And because the physicians are the owners, then we make sure that everything is kind of rowing the boat in the same direction. We're all working towards getting really, really good outcomes for our patients. So the group looks like this. We are 20 neurosurgeons, 5 PM&R doctors, 20 advanced practitioners, 30 physical therapists. We have care coordinators and another 230 or so employees. So you're looking at an organization of about 300 people to keep the entire business working. And as you can see, they're all remarkably handsome people. So all of this is to get the business working around that one focal point that really is what matters the most. That's the patient. We want to make sure the patient has access to all the services that they need. And this is partly why it takes so many people to do it, because when you're a big organization, the patient will have touch points in your company at a number of different points. Many patients come to us, they don't know where to go initially, so somebody has to help them get scheduled and help them find the offices. We make sure we have a few offices around town, so we try to make sure they get to an office that is convenient for them. They need to understand how their insurance is going to work. When they first come in, they might need to be first vetted by a nurse practitioner to see where they need to go first. Is it somebody who needs to see a surgeon, or can they get by with seeing physical therapy or something else first? Many of our patients, even those who end up having surgery, might try non-surgical care first. That's where the physical therapists and the PM&R doctors come in place. So there are a lot of different people that may cross the path of every patient, which makes it important to ensure that we all kind of understand what is the goal here, what is the service that we can provide to that patient. As an independent practice, Again, we remain independent, but we collaborate with all of the health systems here in town. So when a hospital system or a health system needs neuroscience and neurosurgical care, typically we create a contract with them saying that what we will provide, it spells out the kind of call coverage that we will provide for them, the scope of service that we're willing to provide there, because some hospitals are equipped to handle some things, other hospitals are equipped to handle others. And we want to make sure they understand what's medically appropriate at their own institution. And if they want to expand their services, we help provide administrative support to show them how to do that. So we are true partners with these hospital systems in helping them to build the kind of program that they want, and by providing the service that they need. To do that, we're covering a number of different hospitals. You can see these 5 different points here are the main hospitals that we cover, where we actually put boots on the ground with neurosurgeons to go into those hospitals and see patients or into our office points. In addition to this, we have our own independent offices around town for clinic visits and things of that nature. But you can see why it takes 20 neurosurgeons when you're covering this many different hospitals. There are 6 different hospitals all over the city. Some of them are very, very busy with neurosurgery problems. Others of them are not. But we provide, again, the level of service that is medically appropriate and ideal for that particular institution. And by doing that, we can cover all the health systems, which is in a region of about 3 million people. So this is a little bit about the business itself. Again, because you have a lot of people, a lot of points of service, a lot of geographic territory to cover, it takes a lot of money to do some of this stuff. So as you can see, we put a lot of money into expanding and improving our office spaces and our service sites for our patients by upgrading our facilities, including the surgery center itself, by adding additional people to the team so that we can provide greater access to people. We found that having a lot of nurse practitioners who are very well educated on how to manage, in particular, things like spine, that we can provide much greater access to people, because there are more individuals in our group available to see patients urgently or quickly and get them to the care that they need. You're going to hear more about that a little bit later today. We also look at the constantly changing medical technology. What is the best service, the best, safest service that we can provide for our patients? So we need to buy new equipment at times. And then we're also investing in education and research for our patients as well. You saw when I showed you the corporate structure for Mayfield, I saw that one of our vice presidents was for a chief strategy officer. And I mentioned that that's because we need to kind of stay ahead of the curves and the changes in medical economics as they're coming. And this is partly what you mean by that. Hospitals have their own independent challenges. Many of them, as you probably have heard, have had terrible, terrible financial challenges because of COVID and because of the loss of some of their productive elective care that they've been doing. A lot of things are also moving to outpatient, which is another pressure on them. So the hospital's needs are changing, and we need to understand how they're changing and be prepared to still provide the service that they need. So we need somebody who understands that kind of change. We want to maintain our own independence so that we make sure that what we're doing is what we think is appropriate, not just what the hospital wants, but rather what we think the patient needs. And then there are a lot of challenges with the reimbursement that cover not only the hospitals, but also private practices. There's something that people call the silver or sometimes the gray tsunami, and that is all those baby boomers who were employed for many years with private insurance, which pays pretty well and helps keep medical practices and hospitals afloat, that are going to be switching over to Medicare here over the next several years. Medicare, as you may have heard from other talks, I'm not sure, but Medicare does not pay anything close to what private insurance typically pays. And what's more, you don't get to negotiate with the government. They tell you what they're going to pay you, and that's all you get. So as those people leave from their employment into retirement and leave private insurance into Medicare or Medicaid, well, Medicare, then you can anticipate that a large swath of the population will be getting the same kind of medical care, maybe even a little more, but at a lower rate. That means we have to look at how to control overhead. We have to make sure that we deliver the care very efficiently and cost effectively. We have to make sure that we have the right physician and staff around. And we have looked into ways of trying to make that more efficient by doing what we call verticals of care. So if you look at that, look across the scope of things that a neurosurgery practice may cover, There are a few things that are really big, like spine is huge. There's a ton of spine disease out there. So that's a big thing that you have to be able to provide that service, or you're just not relevant to your patients. Neurovascular, like aneurysms and stroke, we're going to hear some more about that in my second talk. It can become a very, very big business, because now that stroke has become an interventional rather than a medical disease, that's a different group of people that need to be around, and different kind of service we have to provide. And brain tumors. Then there's smaller things like facial pain, trigeminal care, normal pressure hydrocephalus, Chiari malformations. We cover all of those things, and we have people who specialize in all of them, but we have to recognize that the way you deliver care to all of those different kinds of disease states and the patients who have them is different. So we have to build a different structure. So as a result, these verticals of care look a little bit different. For spine, we recognize that people don't necessarily want to go very far for their spine care. So we have to have everything kind of in-house. It's much more efficient for the patient if they can come and see their physical therapist, their PM&R doctor, and their nurse practitioner and their surgeon all within one practice, because that way that practice is communicating with each other. They're all working from the same clinical protocols. They're all working on the same electronic medical record. Communication is better. Throughput is better. The patients get better care that way. Stroke is not the same way. Stroke is a very, very time-sensitive disease. As a result, our philosophy has been, it doesn't make sense to bring everybody into one center for stroke care. We have to have centers all around the community in order to try to get that care to the patient, so we can do it very quickly. It also means you have a bunch of different people. You have to work with neurocritical care doctors. You have to work with the ICU nurses. You have to work with emergency room physicians. You have to work with medical neurologists. We have to be able to provide surgical and endovascular care. So that means you have to collaborate with a lot more people too. So that this is not something that works as a one-stop model. In much the same way, but for different reasons, tumors the same way. Where we feel like you've got to work with neuroradiology, you've got to work with neuropathology and neuro-oncology. We work with ENT doctors who are neuro-otologists that provide skull-based approaches for us. We work with radiation doctors. These are all outside of our practice, or largely outside of our practice, and we have to be able to collaborate with them. And the equipment that they use is very expensive, so it's typically housed within the hospitals. So again, we do more of a hub and spoke model to try to provide that care. And then for things like trigeminal, Chiari, other things of that nature, very often these patients are looking around to find out somebody who understands their problem, because it's so uncommon. So we want to provide those services, but we recognize that we have to be able to accommodate people who may be traveling to come to see us and are looking for somebody who can deliver that care really efficiently and in a patient-sensitive manner. So it's a little bit of a different service model. So when we look at the two main models that I mentioned, the one-stop model, what we try to do is make sure that we have care navigation, the pain injections, the physical therapy, the EMG services, all of the X-ray services that we need, the lower level imaging, as well as outpatient surgery, all contained within one service line, so that we can move the patient from one piece to the next very seamlessly as needed. But when it comes to the hub and spoke model that we use, say, for tumors and for vascular, we recognize we're partnering with multiple hospitals and care centers around the community. So we have to be able to integrate all the information that comes from those different specialists and be able to partner with them. So you have to build relationships with those other specialists in those other areas of care. So it's a little bit different. As a result, and this is, I think, fairly typical of a neurosurgical practice, you're going to look at this and see that, again, as I mentioned, spine is the major source of business for a neurosurgical practice. It's such a common disorder out in the community that we see over 10,000 new patients with spine problems every year. And as you'll notice there, only about a little over 4,000 end up getting surgery. So you're looking at maybe 40%, 45% who gets some surgery. And that's a little bit misleading too, because some patients come in specifically with unique spine problems. If you're looking at the more common spine problems with just back pain, for example, about 80% of those patients that we see never need surgery. We can actually manage them without the operation. So you have to be able to manage and care for a lot of people. And only a fraction of those are going to come all the way through to the neurosurgeon that actually need surgery. Neurovascular is very, very different. In that situation, most of the people we see, we're seeing actually through the emergency room. We're not even seeing them in the office first. So new patient visits might not be an elective office visit. And the ratio of procedures that we perform to patients that we see is going to be very, very different. Again, totally different care model. Likewise with brain tumors. Almost everybody who comes with a brain tumor, not everybody, but a lot of people with brain tumor, they're going to need care for that tumor. So that might be radiation, that might be radiosurgery, it might be an operation, which includes stereotactic biopsies. So again, the ratio is very, very different. But that's a little bit how the volume of practice breaks down. And this, I think, fairly typical of a neurosurgical practice. So because in particular in spine, that ratio of number of patients to number of surgeries is so very different, so very low, well, I guess the ratio of patients is high, you need to be able to accommodate all those patients. So you can't ask a neurosurgeon by him or herself to see all of those patients and manage all of their care. This is why we've put together care teams. So you're going to meet my partner, Dr. Tobler, here in a little bit. We're using him as an example. He's been at this for a long time, and he's had a really great career, and it's helped change a little bit the way that we do spine care. So what he does, he partners with the care provider, non-physician, like an advanced care provider, who understands all of his protocols. He educates that person, makes them really knowledgeable about the way he wants to manage spine care, so that that person, while they're not in the OR, can be managing some of the non-surgical issues and handling patient calls, seeing new patients for evaluations, so that his time is better spent in the operating room. Obviously, there's some time out of the operating room as well, where they collaborate and work together. But this basically makes a surgeon more than one person. It makes a surgeon more accessible to more patients. And that's kind of what you have to do in that situation. And we also recognize that patients need to really understand and feel comfortable with the care that they're getting. So that doesn't mean you meet them once, tell them what they need to do, and expect them to show up and do it. It means before they're even ever coming to see you, we need to have some access and information provided to them. So we leverage technology to do this by sending out text messages and the like to get things together, make sure they understand what's going to happen before they come in. Then they come in and we let them know what's going to happen and educate them, get to learn their problem. Then you start establishing their care. But when they've left their care, then you have to make sure that you give them some instructions on how to manage their problem after they leave. That's not even enough. If you tell somebody something once, they're not going to remember. If you tell them twice, they might remember. If you tell them 3 times, then they're probably going to remember. So you have to go back and follow up with people even after you're done providing their care. So this is kind of how we approach things, by trying to say we want the patient to feel like they can get everything they need in our practice. And that, I think, is a really important care model, because it helps to avoid some of those errors that happen in transitions of care and things of that nature. So really, we feel like it's a way to make sure that the quality of care you provide is at its best. So I'll stop there briefly and ask if there are any questions from anybody or anything I can address.
Awesome, thank you. That was a really great introduction to the practice models, and we already got a comment that it's nice for folks to see the different career types when you present it on the private practice versus academic versus private. Because again, like you said, we're so siloed in the academic and hospital-based environment for probably the most formative years of our training that we don't think beyond that, especially at this early stage of medical school. So if any folks have questions, feel free to put them in the chat. I have a question to kind of kick it off with here. So you talked a little bit about technology, and we heard a lot about telemedicine throughout the COVID-19 pandemic. How is Mayfield incorporating telemedicine, if you are, and what does that kind of look like for your practice?
We do. So we use telehealth visits not uncommonly for patients who may have to travel a long way to come in for their office visit. I mentioned some of the things we kind of consider destination care. So we may have patients. I've got patients that I follow from Alaska, New Mexico, whatever, from all over the place. And it's way, way simpler for them just to dial in and have a video chat with me so we can talk about their issue, talk about their imaging findings, what have you. It also works really well. So, again, when I'm managing patients who have had ruptured aneurysms and strokes, it's not uncommon those patients land up in nursing homes or in rehab centers for a long period of time. And a transportation of those patients to the office is costly. It's difficult. It sometimes puts the patient at risk. And it's also sometimes hard for the care center to coordinate with our schedule and with the family's schedule. So sometimes a patient shows up, there's no family there, and it's really hard to communicate or understand what their needs are. So when we can do it by video, somebody can simply have the camera there with the patient in the rehab center or in the nursing home, and the family member might be at their own home. And we just triangulate and all talk about it. And that really helps to improve the communication. There's obviously, from another point of technology, and this is not necessarily just telehealth, but just imaging transfer. So patients who may have been traveling when they had their incident and they had an MRI done in Florida or wherever else, the fact that we have electronic communication with all these PAC systems means I can get those images almost instantaneously. I can see them. The patient doesn't have to drive to the hospital, have a CD burned, and then drive to my office and bring it in or something like that. It's way more convenient that way. A way that hospitals are using telehealth, and I'll tell you one of the main hospitals where I work, the Comprehensive Stroke Center that I staff and helped build, the neurocritical care staff there, who are very forward thinking, are looking at using telehealth to help provide neurocritical care consultation to other outlying hospitals that don't have that kind of staff in the hospital. In particular, some of the places where I and my team might go to treat strokes, for example. So if we go somewhere to a smaller hospital, treat a stroke, the patient stays there, but they have a question, the ICU staff is wondering about something, they may be able to use telehealth to communicate with a neurocritical care specialist at our comprehensive center who can help guide them through the decision-making in the workup, or if necessary, instruct them to transfer the patient. So again, what we're trying to do is minimize the transfer of patients. That's a big expense. That's a potential risk to the patients. And you can use telehealth to minimize that cost and risk.
Yeah, that's really great to hear. One other question before we move on to the cranial focus talk. So a lot of the topics we're talking about here, it almost sounds like we're, doing a little mini executive health, MBA style, class. For folks that maybe don't want to take the leap and get an MBA, and maybe that's, right, it's probably not necessary for every neurosurgeon to do that. How could they, become a little bit more well-versed in these topics?
Well, so there are like short courses available to people. There are a number of institutions. Harvard Business School, I'll just use as an example. I've been to a couple of their brief courses on leadership style, on management, and on medical economics. You can do, and they're available from a number of other institutions. You don't have to go to Boston. And of course, a lot of things are online these days anyway. And so you can do 1 day or 2 day courses on things, at least give you that 30,000 foot view, which help you to understand the vernacular. That's one thing, that sometimes you sit there in a business meeting and you don't even understand what the heck they're talking about because you don't use that language. Just understanding the terminology can be helpful. And then I think, again, as I described some of the differences in practice patterns, I totally understand why a physician might be drawn to the hospital employed model, where you just don't have to do anything. All you do is you go in, show up every day, you take care of patients, you do your best to take care of them, and you go home. That I understand the simplicity and why that would be attractive. I can tell you that at an early stage of my career, I understood that even more. In my current stage of career, I understand the other model way better. The ability to flex the medical need to build the business plan, I think, is really important, because it's very easy for people to get down a rabbit hole, build a business plan that makes a lot of sense from the dollars and cents standpoint, but doesn't make sense from the patient or the medical care standpoint. So I have found it really invigorating to be part of a physician-owned practice that runs a very efficient business, because those two goals run hand in hand. And we never, ever want to lose sight of the quality care we provide to our patients, but still want to do it in an economically feasible way. So that I have found to be really stimulating.
Yeah, absolutely. And I think with so much talk about burnout, a lot of that seems to be related to being in a system that you feel you can't control or you can't provide that
Right.
exceptional care to your patients. So it would almost be an interesting, research question to ask if physicians who are in some of these leadership positions maybe are a little bit more resilient to burnout because they feel more in control of those things.
Well, I'll tell you that some people have done that work, that type of research, and it's really by survey more than anything else. But
Sure.
I saw one recently, and I'm going to screw up the specific details here, but there was one that did show a certain number of questions about that were related to burnout, but specific aspects like fatigue, uh, job satisfaction, other things like that. And then the data was sorted out based on practice type,
Sure.
and physician-owned practices showed much more positivity, much more optimism
Mm.
in their answers than hospital-employed physicians. Now, I'm not poo-pooing that job. Don't get me wrong, but you are correct. I think that just having a sense of control over things is a big piece of job satisfaction.
Awesome. Well, thank you for again that intro, and why don't we move on to the cranial focus talk?
I'm on a call today. I'm going to really quickly, so I
Sure.
haven't look at my phone here. It's been buzzing.
Sounds good. Let me. I'll put up this slide so we're ready to go when you are.
Okay, I think that'll stop it. Okay.
All right, slides are up. So whenever you're ready to switch on to the next one.
Okay.
Perfect.
So we talked a little bit about some of the verticals of care that we built within Mayfield. So I'm going to focus on the two of the more common cranial ones, the vascular and the brain tumor models. So those will be a little bit more clinical discussion than the last one was. Again, for each of these, because of the need for lots of expensive technology that's too much for a single practice to be able to own, house, and maintain, because of the need for a lot of in-hospital care, because in particular with regards to vascular, the urgency of care that's necessary, we typically use this hub and spoke kind of model for our cranial patients, where we collaborate with other specialties and other hospitals and care centers with the kind of care that we provide. Looking initially at stroke is becoming as I mentioned before, a really, really big part of neurosurgery business. When I first went into neurosurgery, it was just a speck on the wall. It was something we almost never did. I probably in my first several years of stroke of practice rather would do maybe one stroke intervention every couple of weeks. I would maybe do or even one a month perhaps. Now we're doing more than one in a day. It's remarkably different, but that's because of the way the model has changed. Stroke, as you might be aware, was initially the first treatment available for it was TPA. That was in 1996. Before 1996, there was no emergency treatment available for stroke, none at all. It was all just medical supportive care. That was applicable to a certain population of stroke patients, the smaller strokes and very early strokes. And then over the past several years, in particular since 2015, we've recognized that doing an intervention to grab a hold of the blood clot that's occluding the artery and pulling it out, what we call a thrombectomy, is very, very effective, in particular for the bigger strokes, the more serious strokes. And as more and more research has gone into this, we found that works for more and more patients. People we thought never had a chance for any kind of treatment actually do have a chance with this intervention. And then the kind of the backstop when we're not successful in stopping a stroke, and it does go on to happen, if the patient was otherwise reasonably healthy and not too old, we can actually help them recover from their stroke better by doing what we call a decompressive hemicraniectomy. What that means is we take off a big piece of bone roughly the size of my hand from the side of the brain that was affected by the stroke and open the dura, which allows the brain to swell under the scalp, or the closed scalp, during the early phase of that stroke, and then kind of contract back. Without that operation, the swelling occurs. It causes an increase in intracranial pressure. It decreases perfusion to other parts of the brain and actually exacerbates the stroke and the disability. So patients who have suffered a stroke despite our best efforts still might have a better chance of survival and better functional recovery if we do this decompressive surgery for a really large stroke. Now, identifying patients who need stroke and what kind of care they need is a little bit complicated. I show this algorithm here not because I want you to memorize it, but because I want you to understand how complicated it is. There are a lot of different decision points that need to happen to help us decide what kind of care that patient needs. And since not all levels of care are available at all hospitals, you have to get through this algorithm to figure out what the patient needs in order to decide where to take them. That's part of the reason why we have felt it's really important to develop stroke centers all around the community. So when I started, I don't think this is, no, this is not. When I started, the only place we treated strokes was right here at the university. That was the only comprehensive stroke center, the only interventional stroke center at all. Through Mayfield, we've helped to build another one at Good Samaritan. We opened 2 in the northern side of town, and this summer we're opening another one south of the river in northern Kentucky at St. Elizabeth. But you can see that these are now geographically distributed in such a way that the population, a great portion of our population, has an easy travel to a place they can treat their large, more complex strokes with that thrombectomy procedure. Though part of the way we manage such a large geographic space is, again, by leveraging technology. So there is a company called Viz AI, and AI stands for artificial intelligence, that serves as a rapid communication module to help us work through that complicated algorithm as instantaneously as we possibly can. What typically would happen prior to using that kind of communication model, and that's an app on my phone, before that was available, patient shows up in the ER for a stroke, they're seen by the ER doc, sent for a CT scan to make sure it's not a hemorrhage. That is read by the radiologist. They call the stroke neurologist to say, nope, no hemorrhage, looks like it must be a stroke. They decided they should give thrombolytics and say, well, it sounds like a bad stroke. We should go get some advanced imaging with a CTA or maybe a CT perfusion to see if this is eligible for intervention. It goes back to the radiologist, who calls back to the ER and says, yep, they look like they're eligible. They call me or one of my partners, and then we transfer that patient to the place that can get that kind of care done. As you can imagine, that takes a lot of time. With this app, what happens is we have installed basically a splitter at all the ER scanners for all the hospitals that we cover. And I don't mean just the thrombectomy ones, but all of the stroke hospitals. So there are about 15 hospitals that have this service available, such that when the tech has processed the images and hits the button to send it to the PACS system, it simultaneously goes to a cloud-based server where the AI algorithm lives, which has been trained to recognize gray-white scale color pictures that are consistent with a large vessel occlusion. When the robot, as I call it, identifies an LVO, then it sounds off an alarm on my phone and everyone else on the care team that sounds like an Amber Alert, so you can't even possibly sleep through it. I pick up my phone and I look and I say, yep, looks like there might be a blocked artery there. Then, using a HIPAA-compliant communication and texting module that's in the same app, somebody reads that scan and sends out a message that is received by everybody on the care team simultaneously. That's the ER doc, the stroke neurologist, the interventionist, sometimes the ICU doc as well. So we go through all that, make our decision, we decide what should happen to that patient. Then afterwards, we get all the way through this, and in a matter of just about 30 minutes, we've already gotten the patient on a helicopter to fly to get the thrombectomy done. And this one is the message for me, the TICI-3, that's thrombolysis in cerebral infarction. 3 is normal. That means we restored that patient to normal perfusion afterwards. So this dramatically improves the throughput for our stroke patients. Now, there are other vascular disorders that don't have quite the same time sensitivity as an ischemic stroke. Aneurysms, vascular malformations, things that can cause other forms of stroke, like hemorrhagic stroke, that we still also manage. Sometimes we manage those more electively. These patients might present with unruptured AVMs or aneurysms, and then we have to decide what to do with them. So in that case, particularly when the decision-making is not straightforward, we love to collaborate. So we run a case conference every Thursday morning, and it's not just people in my own practice. We We have people from all over the region who dial in, and it's done virtually again. We review cases. So these are people who are in academic practice and private practice. That we have one of my former fellows in Florida who's doing this. And we get on and we just, all of us share our cases and talk about it. And once a month, we even review to sort of a journal club to review it. This is part of the way we help to make sure we're staying current and that we're really leveraging the decision-making of multiple people to make the best choice for that patient. We also recognize that there's a level of care that needs to happen after the patient gets their lesion treated. So you treat the stroke or the aneurysm, and you're treating that patient in stage 1 for their acute care. They'll eventually have to go to, many of them have to go to rehabilitation or nursing facility for a little while. They might then come home, but they still need some care at home. Then they're going to come back and see you, and they, in particular for the case of aneurysms and things of that nature, will need some outpatient care. I follow people with treated aneurysms for 5 years. So we take care of them. We monitor their aneurysm. We get imaging. Our office manages it for them to let them know when they need the imaging, just to make sure that that aneurysm is never, ever coming back. Even for the ischemic stroke patients, there's a lot of different potential sources of stroke, a lot of different specialists who might treat that. So we want to make sure that the patient is navigating the healthcare system in such a way that they're getting to the right person to get the right preventive care afterwards. So you can't kind of back off after initially doing that treatment. You still have to maintain that hub and spoke model. You still have to be able to collaborate with the other specialists. You still have to have open lines of communication and be prepared to ensure that you're getting the best care. So if you like the idea of doing that kind of stuff, here's how you can do it. The treatment that a dual trained endovascular neurosurgeon provides is aneurysm clipping through craniotomies, aneurysm coiling through endovascular approaches, AVM resection surgically, AVM embolization. We even have a neurosurgeon who does the radiosurgery for these. We treat carotid disease through endarterectomy or through carotid angioplasty with stenting. I might treat patients with rare disorders like moya and carotid occlusion with cerebral bypass surgery or acute strokes with thrombectomy. All of this is available to you if you go through that training to do an endovascular fellowship after neurovascular treatment. I'm sorry, after a neurosurgery residency. So neurosurgery residency, if you do a residency, you will get some endovascular experience. If you decide you really like it, you'll do a fellowship for at least 1 more year after your residency to get it all done in all likelihood. But this is the kind of care that you can provide if you do that training. Now, not dissimilar to the way we do the vascular care is the way we do brain tumor care. This is a picture from the brain tumor board at one of the hospitals that we serve, where again, you've got multiple different specialists, all of whom are participating in the same care for the same patient and deciding what combination or approaches of care are most appropriate. It's a little bit less time sensitive, a little bit more, I guess, deliberate with regards to choosing the best care for that patient. But it's a very similar model because, again, we need care available for our patients that we don't house within our practice. We don't have gamma knife units that we own. We don't have linear accelerators. We don't have neuro-oncology infusion centers. We don't have things of that nature. So we treat a lot of different things. In order to make sure that the patient gets the best outcome, we have to collaborate with other specialists to do that. These include malignant tumors like glioblastomas, benign tumors like meningiomas, functional tumors like pituitaries or acoustic neuromas, and some of these we treat with radiosurgery as well. So there are a lot of different ways that these brain tumors are treated. Sometimes patients have a tumor that's in a very sensitive functional area of the brain, and our surgeons want to be able to monitor that function and to ensure that they're not injuring it during surgery. So they might actually do awake craniotomies. We sometimes do continuous EEG recordings or other electrophysiology during surgery. Some of our pituitary tumors, for example, are taken out using an endoscope. So these are a lot, and there's intraoperative imaging like a CT scan or an MRI inside the operating room. And then there are specific chemical tests that can be done during surgery to help elucidate the tumor. That's the ST5-ALA that you see there in the middle. So this kind of technology is the kind that can be housed within a hospital because they're going to have the volume and the infrastructure to be able to support that. And then we can help the hospital decide which of these expensive technologies is really worth it and which is just a waste of money. That's part of how we can collaborate with the hospitals to make sure that they're providing good care, but not spending money they don't need to do. We also need to collaborate with other specialists to do this. So my partners who do some of the skull-based surgery, they have to understand the various different approaches, the big operations, the small operations, and they have to be able to collaborate with other specialists like the ENT doctors, the eye surgeons, the otologists. They work with radiation oncology and medical oncology to ensure that they are getting the best collaborative care for that patient. The radiosurgery team usually involves a radiation oncologist and a neurosurgeon to be able to do the planning together. They treat metastatic tumors, malignant tumors, even sometimes benign tumors. This can be done either through using a pin-fixed frame on the patient's head to help to localize, or a custom molded mask that has visible MRI visible markers within the mask. I like to tell patients that this is a little bit like the GPS in your car. It just uses that localization technology by triangulation of images, by looking at the markers and identifying where the lesion is. Or you can also consider the gamma knife to be something like spotlights on a stage. If you're sitting in the audience and multiple spotlights are coming over your head, each one of them is kind of dim. You don't really even notice them. But where they crisscross on the stage where the star is standing, it's super bright right there. And that's kind of the way radiosurgery works. You don't want the normal brain and the skin and everything to see that same high dose of radiation. You only want it right where the tumor is located, right where the AVM is located. So by doing this, you get multiple low dose beams going through the brain, which will have virtually no effect on it, but a high dose right where it crisscrosses. So as you can imagine, there's a lot of planning that goes into making sure that that is accurate down to the 10th of a millimeter. It's really very, very precise. So when a patient comes to us with brain tumors, we understand that their needs are going to be different than the next patient or than the prior patient. So that's where they have to be seen by a surgeon who can collaborate with the medical oncologist and the radiologist to make sure we have the right diagnosis, understand what that is through sometimes biopsy of the tissue, for working with the pathologist. That patient is going to have some recurring treatments occasionally, whether that is coming in for repeat imaging, repeat radiation treatments, repeat chemotherapy treatments. And so an oncology nurse and a physician assistant or a nurse practitioner can help that patient navigate that, maintain the schedule, understand why they're doing what they're doing. Again, so that you're not using a surgeon's time to do the things that aren't that person's specialty. And you want the surgeon their time to be used as efficiently as possible when it's necessary. A lot of this decision making is made on a weekly virtual brain tumor board. We run brain tumor boards for each of the different hospital systems with whom we partner. So they all have their own, but we do it by basically the same way for every hospital system. It all involves multi-specialty review of each patient. That's radiology, pathology, neurosurgery, neuro-oncology, radiation oncology, everybody in the same room or same virtual room, all at the same time, looking at the same images, talking about the same patient, understanding what that person would need, and agreeing on a plan. So one of the ways we make sure that happens is we hire people, the two ladies you see here, who do that work for us. They help to make sure that patients who are going to be reviewed, that we have all the information we need. They load all of those images, get them ready to go for the brain tumor boards. They provide education to the patient so that they understand what they might need. They'll even educate hospital staff on what the patients may need and what the reason is for their care protocols that we have. They coordinate that, help support the patients and their family to navigate through all these various myriad different treatments and people they might need to see, and they ensure that they get the right follow-up. So their job simply is to make sure that everything happens the way it's supposed to happen. And this is part of that quality control to ensure that that's going to happen every time. So if this kind of work is interesting to you, that's something that you can do as a neurosurgeon also. After neurosurgery residency, some of my partners have gone on to do neuro-oncology fellowships where they specifically look at surgical treatment for brain tumors and the like. Some of them have gone on to learn about radiation oncology and radiosurgery. So you can do either. You could do both, I suppose, if you really want to do everything. But additional subspecialty training is available in each of these things. So these are the kinds of things you can do as a neurosurgeon after residency by doing subspecialty training. So again, the model that we provide for most cranial care really involves a lot of collaboration with other specialties, other hospitals and hospital systems, and providing a lot of support staff to help the patient navigate their way through all that care. So I hope that was fairly clear. Again, we'll stop here and ask if there are any other questions.
Great, thank you. So you mentioned, and I think the YouTube algorithm probably went crazy when you talked about artificial intelligence, since that's such a hot topic right now.
Right.
But where else in neurosurgical practice, and specifically in that kind of care delivery realm, do you envision artificial intelligence coming into play?
So that's a great question. I think one of the first places we'll see more of it is in imaging. Most of what I showed you for the stroke model, that was advanced imaging for stroke and urgent early notification of the care team through an AI model. That same model now is also available through the same company for pulmonary embolus. So some of the hospitals have this in place for PE monitoring to try to identify it early to see who might need ICU care, who might need a vascular surgeon to come in and do a pulmonary thrombectomy. But also, I've spoken to some radiologists who think that it may be part of a sort of a quality assurance model for radiology and image reading, where AI can help assimilate multiple different interpretations of the same image from multiple different radiologists, decide which is the most likely correct answer, the most common answer. And it's almost like a blockchain work where the right read to that particular image comes from multiple different opinions that AI sorts out what is the most common correct answer. These are things that I barely even understand, but that are likely to come in and help advance our care. Now, beyond imaging, AI might also be used once we get into really more what we call biologic agents for tumors, rather than the traditional chemotherapy. When we're looking at agents that are specific to gene mutations, then AI might help us to sort out a very broad gene spectrum analysis of every tumor that's had to help identify the best biologic agent for that specific tumor, regardless of tissue type. So we might see some movement there. But there are a lot of different ways. AI really, if you want to think about it this way, is probably best described as a way of assimilating massive tomes of data and making a decision quickly.
Right. The whole idea of big data analysis, which I know is becoming more and more popular in neurosurgery, and now I think it's the CNS is incorporating some of it into their scientific sessions, which is exciting. I also appreciate that you put in a little bit of a practical point on what the training paradigms look like if you want to go to the various subspecialties. In making that decision, how do you kind of evaluate the factors for what fellowship is going to be right for you? Let's say you're interested in vascular. Do you need to do an endovascular and then like an open cerebrovascular fellowship, or is it kind of dependent on the training that you got during residency? And kind of similar for, I guess, neurosurgical oncology, what that looks like.
So that's a great question. And I think your last point is most correct. So every neurosurgery residency program has different strengths and weaknesses. There's probably no perfect program out there. There's some that consider themselves perfect and probably are pretty close, but there are some that are really strong in spine, some that are really strong in tumor, some that are really strong in vascular. So it depends a little bit on where you go. And it also depends on the experience you have while you're there. If you're coming out and you're a senior level neurosurgery resident, and you feel really, really comfortable with craniotomies, and you feel really, really comfortable with vascular exposure, then you probably, and you want to do cerebrovascular work, you should probably do a high volume endovascular fellowship. But you probably don't need a surgical fellowship to hone your skills further. If, on the other hand, you've had a very general exposure and you feel okay about craniotomies, you feel You still get a little nervous about clipping an aneurysm or something like that. Well, I guess everybody does, but you get kind of a lot nervous about clipping an aneurysm. Well, then maybe you want to go to a place that does a bunch of both. Or you might want to do one endovascular and one surgical fellowship. Personally, I like the ones that do both. I think if you are in a fellowship that allows you to do both of them, open and endovascular, that's a more real world application. It is true that in cerebrovascular world, more and more the shift is going towards endovascular. When I started practice, I probably coiled about 60% of the aneurysms that I treated, and I clipped about 40. I'll bet you today it's 80-20. It might even be 85-15. And that's just simply because the technology has changed to make endovascular care so much easier, simpler, and safer that becomes the modus operandi for most vascular surgeons. So as a result, it's going to be harder and harder to get that surgical experience. So that may be something to consider as well.
Great, thank you. I know that's something that's always on our minds as students and residents thinking about furthering our training. Well, I don't see any other questions in the chat, so maybe we can go ahead and move on to Dr. Tobler's stuff.
Sure, we'll do that. Guys,
Awesome.
Thank you so much. I'm going to miss the panel discussion at the end because, as I mentioned, I'm on call, so I'm going to have to run in and see some people in the hospital.
Sure.
But it's really enjoyable. I appreciate the opportunity.
Yeah, thank you so much, Dr. Ringer. It was a great series of talks. We appreciate it.
Thank you.
All right. So let me make sure that we have our screen up there. Perfect. So it's my pleasure to introduce Dr. William Tobler. Dr. Tobler is a spinal neurosurgeon with expertise in minimally invasive spine surgery. He completed his undergraduate studies at the University of Notre Dame, his medical school at the University of Cincinnati. He did an internship in both internal medicine and general surgery, followed by residency in neurosurgery at the University of Cincinnati Medical Center and the Mayfield Clinic. So he's a Mayfield alum and a lifelong Mayfield surgeon. So he's going to be sharing his experience in really innovating spinal care in the one-stop integrated spinal center at the Mayfield Clinic. So thanks, Dr. Tobler, for taking the time to join us today.
Thank you. Happy to be here. Listen to Dr. Ringer's discussions with great interest, and we are going to speak to the one vertical here of spinal disease. But before I start that, I want to make some general comments to the medical students, because I'm a senior neurosurgeon looking toward the end of my career, and I've been about this for a long time. When we started, we did not have all of these various subspecialties. And so that in the early days, I did everything. We did a lot of vascular surgery. I did a lot of brain tumor surgery, a lot of spine. The thing that has happened in the last 30 years is that technology has advanced tremendously. The capabilities of what we can do have expanded immensely, and therefore it makes it very difficult for a neurosurgeon to be versed and experienced and practice in all of these different areas. Now, in remote areas around the United States, that might be different, and you might see the practice that Dr. Ringer showed of the simple neurosurgical organization for a 2 or 3 person neurosurgery group. But in all of the metropolitan areas where you have 1 million or plus catchment area population, you're going to see the subspecialization into these various areas or verticals, as we're calling them. So I think for medical students, it is a difficult choice to decide what you want to do at a very basic level. Do you want to be in, a surgical specialty or a non-surgical specialty or some other allied kind of specialty? And so it's a very daunting to sit through these presentations and look at the sophistication of the finished product that we have at Mayfield. So in a fundamental way, making those early decisions are important and occupy, all of your time. And in medical education, you are not getting exposed to so much of what you've seen here. The fact is that the delivery of medical care has changed a lot in 30 years, and it continues to change, and it's being driven by internet technology and the cyber world that we live in, and patients' expectations are higher than ever. And so now we've become oriented to actually delivering a product. It doesn't matter whether you are an employed physician or whether you're in private practice or you're in research or you're in academia or in privatemics. Patients are everywhere and they demand much higher expectations. So we've developed into kind of a corporate model, and we look at it a little bit differently. Is we're not just doing an operation, we're delivering patient care, and we have to deliver satisfaction, and we have to make that a continuous process. And I'm very proud of what Mayfield has been able to accomplish, because we believe that we're on the cutting edge of presenting very high patient satisfaction. So I'm going to speak more directly about the vertical of the spine model. So in contrast to brain tumors and vascular, we have found that building a model that contains everything within a single organization provides a great degree of patient satisfaction. For example, the majority of the patients that we see in spine don't end up having spine surgery, but they have many experiences along the way. They get x-rays, they get MRIs, they get physical therapy evaluations, they get many non-surgical forms of treatment. And it becomes extremely fragmented in many communities when a patient has to go from one place to another to get all of these things done. You see a doctor somewhere, he sends you for an x-ray or an MRI, and usually those are two separate places. And then you might be sent to physical therapy, which would be yet another place. And then it's sent for some kind of a pain injection, which may be yet another place. So that becomes extremely awkward. And so in developing the business model and the delivery of a product, we are striving to make it as seamless as possible. Now, there are some things that we can't contain within the realm of our own private practice organization, such as very complex surgery that requires inpatient stay in hospitals and in tertiary hospitals for many of the things that we do. Many of these surgeries cannot be accomplished in some of the outlying hospitals because they're not capable or equipped with the sophistication and equipment necessary to do some of the very complex spine procedures that we do. Postoperative care, especially for hospitalized patients, is also something, at least at this time, is external to our Mayfield model. And now that may change because we're looking at some of those options in the future, and that's what our development team engages in. So for integrated spine care, we see large volumes of patients, and we have various different teams that work within the confines of the Mayfield organization, including our advanced practice providers, and those are physician's assistants and NPs, nurse practitioners. And many of these are highly qualified, highly trained people. And in fact, many of them certainly could be physicians themselves, but for lifestyles and various reasons, they choose to take a different pathway. We have built and integrated an incredible physical therapy team, and we now have that in all of our locations. So our Mayfield practice, again, it is in the Southern Ohio region, with Cincinnati being the metropolitan area. And we have 5 locations. We have a location in the very center core, and then we have a location at the very northern end, the very southern end, the eastern and western sides of the region. And we work with our physical therapy teams in all of those places, and we work with allied physicians, our pain providers, and our physical medicine and rehabilitation doctors. Physical medicine rehabilitation physicians are non-surgeons who are expertise in the management of all issues related to the musculoskeletal system. Many of these are trained as specialists to perform invasive injection pain procedures. And we not only perform injections, but we do some minor surgical procedures such as implantation of pain pumps, implantation of devices called spinal cord stimulators, which are essentially a pacemaker device for modulating chronic pain. So altogether, in addition to the physicians, you see our integrated organization in these various pictures. So just like vascular conference and just like brain tumor board, we have a spine tumor case conference or a spine board or whatever you want to call it. But this is also an attempt to provide analysis of all of the options for treating problems. Now, we don't spend a lot of time dealing with all of the routine sort of everyday problems. We bring the more outstanding or kind of off the bell curve kinds of problems to the spine conference. And it is attended in person, but can also be attended virtually. And it's attended by all of our providers, our APPs, our PM&R physicians, some of our care navigators who learn how to do their jobs much better by understanding the problems that our patients have, and our physical therapists who learn an awful lot by participating in the spine conference. And what we find out is we can't always distill a treatment down to one best option. Spine is very different in many ways from brain tumors or vascular problems, but there are many different options available depending on patient preferences, depending on the skills, the experience that some surgeons have. Not every surgeon does everything the same way. We're trained to develop our skills to the best of our abilities, and there are certain things that we are more experienced than others. And so this is a lively discussion, and it's extremely educational, and it's a very important part of any kind of an academic program. So going back to our model, our care pathways for spinal disorders, patients flow into the organization. And as Dr. Ringer mentioned, we have over 10,000 consults a year. So it's a very, very high volume compared to brain tumors and other disorders. But most of the patients end their treatment in the large box here with non-surgical management. But they have touches along the way, including not only our own physical therapy, but external providers, care providers like chiropractors, massage therapists, specialized therapy individuals. And the wellness concept is a concept that I think that we are going to continue to focus on and try to grow much more in the upcoming years, as we understand that wellness leads to prevention of a lot of the problems that get patients into trouble. So when patients, the smaller percentage, around 30% or so of the patients that we see, end up having a surgical experience, It is usually in one of two facilities, either outpatient surgery in the outpatient surgery center that Mayfield developed, or in the hospital, and into the various hospitals where we all work around the region. And most of the time in more hospitals equipped for tertiary or more advanced kind of spine care. Now, post-acute care, the more sophisticated surgery we have and the more complex, the larger the postoperative care period is. Many of our outpatient patients who have surgical procedures simply give it time and maybe a post-op physical therapy session for about 4 weeks. But many other patients need either inpatient rehabilitation, they need to be transferred to a skilled nursing facility, or to outpatient rehab or home care. And I want to just talk a little bit about the skilled nursing facility piece of it, because this is a large portion of our patients go to skilled nursing facilities. And in the Cincinnati region, there might be 30 or 40 different independently owned skilled nursing facilities. And this is a moment of big opportunity for us, that we recognize that the prevention of complications provides better care, better outcomes, and less cost to the system. And we realize that we don't have much control over what happens in the skilled nursing facilities. So it's an unknown box for us, and it makes us uncomfortable. And in the development of our practice management and delivery care model, we see that as a future opportunity to integrate skilled nursing care within the Mayfield world. So, like other businesses and organizations, when I started in medical school, it was, oh my God, don't ever think about advertising or marketing. That was unethical. That's not what physicians do. And I remember when the first physicians started to pop up with small advertisements, that consternation that sort of rolled through the medical fields was really palpable and disturbing. But that's way in the rearview mirror, because of this being a business, because we're delivering a product, and because we are dedicated to providing the best for our patients, we need to put our message out there. And so this is what you will see in the greater Cincinnati region. You will see these exact banners here on billboards. Sometimes they're pasted up on billboards, and now we have these nice electronic billboards that are popping up all over the place. But we are trying to deliver a succinct message that we are complex, we are everywhere, and we can provide care from start to finish, from the easiest to the most complex. One of the methods that we used to work with a number of years ago as a central way to work with patients, because there were more patients who wanted to be seen than we had the capacity to see. The old model, a patient has a problem, they call the doctor's office, they talk to a secretary, and they schedule an appointment. Well, that doesn't happen anymore. That might be on some old TV shows, but that just simply isn't possible. There are patients that would, for example, want to schedule an appointment to see a neurosurgeon, and it's really not even a problem that has anything to do with a neurosurgical disorder. So we used to work in a process that was all computer-based, called Priority Consult, where a patient would make a phone call to the organization, would talk to an allied health professional. We call them intake specialists. And that intake specialist would do a query, collect data, all of the data that's available that the patient can provide related to the episode the patient's inquiring about. For example, did you have physical therapy? Yes. Okay. Where? When? How long ago? Did you have injections? Do you take medications? Have you had prior surgery? Have you seen other surgeons? Do you have radiographic studies such as MRIs that could be obtained in any one of 100 facilities? And so the nurse intake specialist would gather all that information and put it in a succinct fashion for the surgeon to review. The surgeon would do a triage process in the yellow bar below. The surgeon would look at that, and sometimes it's obvious that the patient needs to have surgery, has done everything else, and needs to be seen right away. That person would be scheduled with an expedited appointment to see the surgeon. The surgeon, only the surgeon, can determine whether or not this is a patient that I don't need to see. This is a patient that needs more therapy, that needs more testing, or whatever. So the surgeon would be the triage point. This would provide efficiency both for patients and for the care providers. And this was a way to be able to with great degree of satisfaction to our patients and physicians to see the right patients in the right place as soon as possible. And that impact has been big for our organization, and it created a lot of satisfaction for our patients because they get moving quickly to get their care. There's a negative downside to that, and that's that there's no touch with the physician, right? So a patient says, go see Dr. Jones. Well, the patient wants to see Dr. Jones. The patient's been prepared to do that, and that doesn't always happen in a very busy practice. And so we have tried to morph this because the demographics are changing, expectations are changing, and we now have a much more trained, available, scalable group of APPs, our associated patient providers, nurse practitioners, some non-surgeons, and physician's assistants who can actually see those patients now very quickly in the location nearest to where they are. So, it's very important part of satisfaction that access is not only immediate, but it's also local, so that you don't have to drive an hour or 45 minutes. So we have pods of APPs and care providers who are able to see these patients more quickly. Maybe you don't see the surgeon on the first visit, but you see the surgeon pretty quickly. So we look at the patient experience from first touch, or actually before they're even seen, until they have completed. So this is more of an analytical model that our administrators look at. And this is how we analyze this and how we try to be available and provide the best care available so that everybody gets the maximum benefit and the best outcome possible. So on a more granular basis here, when the patients start from the beginning and are on this flow sheet, starting with the pre-touch, PC, then coming to the office, being in the facility, and then maybe going through the surgical process. And during that surgical process, pre and post-op immediately, there's an awful lot of information that has to be shared with the patients. And like Dr. Ringer said, patients don't always remember everything the first time. So we have multiple points where re-emphasize the same information and then provide that information in document form, both on pieces of paper and also available on our website. So this goes all the way through the post-op period and long-term follow-up. We follow many of our complex patients for 2 to 3 years or even further. So I'm going to show you just very quickly what our ancillary facilities look like. We have advanced body imaging. This is not an MRI. This is not a CT scan, but this is a very advanced form of X-ray analysis that allows us to get these kinds of incredible pictures of a person's entire skeleton. We can measure them from head to toe, all the way down. We can measure their leg lengths. We can see their scoliosis. We can see how it affects their entire body and posture. This is not a typical kind of a machine that you find in any medical facility or even in the hospitals. Our physical therapy are highly trained specialists in the latest techniques. Their thirst for education is incredible. Their personalities are wonderful, and their talents are exceptional. And we have found like anybody would say, what we own in our business is the best. But we used to work with physical therapy facilities all over the place. And without provocation, our patients come in and they are so laudatory of the physical therapy that we provide, because we are focused and we provide the latest techniques and experience in spades with spinal disorders. Physical therapy in outside facilities is fragmented, right? You're in there with a spine patient waiting in line to see the physical therapist who's seeing somebody who had a shoulder replacement, a knee replacement, sports medicine injury. So it's a grab bag variety of problems, and they're not always focused on the spine per se. And so we control the quality of the product, and that's very important because we know more than anybody what the best product is. The same way with our interventional pain suites. Interventional pain is a very, very big business. There's large numbers of pain providers, massive numbers of procedures throughout the United States that are performed every year. And again, with our own facilities, with our own doctors, we're able to provide the best technology, the best quality. And there are 3 different facilities where we use around the Cincinnati region, including in our most northern area of town called Westchester, and our most southern area of the region in northern Kentucky, which is where the Greater Cincinnati Airport is. And then centrally in our spine surgery center, which we'll talk about in another part of the presentation. But this is a very big crown jewel in the Mayfield organization as our outpatient surgery center that you see here. It's a unique building. It's a beautiful building. We designed it, we equipped it, and we control it, and we maintain the highest level of quality assurance. We opened in 2007, and I was fortunate to be part of the team that imagined that this could happen and then developed it and brought it to fruition. It was a big investment of time and resources. It has 3 operating rooms. Those are on the main floor with the pre and post-op area, which you see on the bottom left picture there. And on the second floor is our pain suite, as well as a couple of other facilities. We have a high-tech conference room, and we have a surgical cadaver training lab. It was funded by our Mayfield Foundation. But with regard to the surgical procedures there, we have 9 patient rooms, and we are completing approximately 1,500 surgeries a year. These are outpatient procedures, which means that you either go home the same day or you can spend a night in the surgery center as long as you walk out the door within a 24-hour period. That's the state definition pretty much around the country of what same-day surgery is. You can actually stay overnight. It's kind of ironic. That allows us to operate on even slightly higher complexity of disorders and provide more service to the patients. We're accredited by all the organizations. We have our own separate website, mayfieldsurgery.com, which you can take a look at and see for yourself what we do in that facility. Our experience there has been nothing short of amazing, because we have the lowest infection rate, the lowest complication rate, and the highest satisfaction rate. And from a business point of view to the healthcare community, we provide those same services at half the cost that is accrued when that same procedure is done in a hospital setting. Lastly, before I stop for questions, is the diversity of neurosurgery, as you're getting a sense for, is a very interesting feature of the field that we're in. And I love those days when I personally could go to the operating room and clip an aneurysm, take a brain tumor out, and do a spine fusion. But that's fading into the rearview mirror. And spine surgery itself is a big specialty, And one other route to spine surgery would be through the orthopedic approach. So orthopedic surgeons also train in spine surgery, but they have a very different training than neurosurgeons do, because in our training, even though the practice is much more divided into subspecialization, in your training program in neurosurgery, you will train in vascular, you will train in brain tumors, you will train in functional neurosurgery, and you will train in spine. And it's during that training period that then you begin to discern where you would like to go with your career, and then develop your fellowship training according to what you have decided. And so you don't really have to start neurosurgery training with a definite idea of where you want to be in the future. If you have that conviction that you know exactly what you want to do, it's all the better. But if you, for example, are interested in orthopedics and interested in spine, then training in an orthopedic residency training program is another avenue to enter the spine world. So I'll stop there for questions, if there are any. Thank you.
Great, thank you, Dr. Tobler. And I really appreciated, your kind of monologue at the beginning, highlighting the changing world of neurosurgery. Because a lot of this can seem very over our heads as medical students, but it's nice to put it into that context. And of course, we weren't familiar with what neurosurgery was before.
Well, you tend to have a feeling that you might be drowning in this tidal wave of information.
Yeah, absolutely. But it's great information. And again, like you said, we just don't get it as medical students anywhere else. So we're really grateful for this opportunity to really hear it from the source. So, one question that I was kind of thinking of as we went through this. So you looked at I think it was one of the patient workflow slides where you showed the pre-exposure and the post-exposure. And then the role that the APPs have in triage. Have you had any, feedback where, maybe this is a generational thing, but patients felt like they weren't getting enough exposure to the surgeon or the physician if they were being triaged by the APPs?
Well, here's the reality of life. The practice of neurosurgery, the practice of any field in medicine, is a service industry.
Mm-hmm.
And the reality of it is, no matter how hard you work on improving your services and facilities, there are going to be problems where communication breaks down, where some information doesn't get past, where patients' expectations aren't satisfied. I mean, you just can't make everybody perfectly happy
Sure.
all the time, and that's just inherent in human nature. Patients are consumers. I mean, patients look at it that they're buying a product. I mean, it's no different than, in a sense, going to a restaurant, right? I mean, when you're in a restaurant and you're flowing through all these stages of your meal, and anywhere along the way, you can get aggravated or upset or offended by something.
Sure.
The next person might not. So we have to deal with the difficulty of that's inherent in a service industry.
Absolutely, yeah. And I think something that has been really highlighted throughout the day's discussions is that as a private practice, in a physician-owned organization, you guys are responsive to those market forces in order to drive better care and increase productivity. And I think that's something that we see, maybe in academia and in the hospital environment that is a little more limited. We're a little cushioned away from some of those market forces.
Right. But we can't do it alone. We do it with the expertise of our infrastructure.
Sure.
And the talented people that we've been able to work with over the years.
Absolutely. Well, I'm not seeing any other questions in the chat just yet, but I definitely want to plug that if anybody does have questions for Dr. Tobler or any of the other speakers through the rest of the day, just put them in the chat. And then we also will have a little bit of time at the end for a panel Q&A discussion. So with that, let me go ahead and share my screen here. And let's get perfect. Okay. How are you doing, Jody Beckington?
I'm good. How are you?
Awesome. Doing well, doing well. So let's see, you're on the screen there. I'm going to just take the Mayfield Center off the screen. Perfect. And I think Tanya has control of the slides, it looks like. Great. So great. Why don't we go ahead and get started? So it's my pleasure to introduce Dr. Jody Beckington, one of the nurse practitioners at the Mayfield Clinic. Dr. Beckington is an advanced practice provider for patients with a variety of neurological disorders, including brain and spinal disease. She completed her undergraduate and graduate studies in nursing, followed by a doctor of nursing practice at the University of Cincinnati. She's certified as an acute care nurse practitioner, as well as a certified neuroscience registered nurse. And this is, a great follow-on talk to what Dr. Tobler was talking about, the role of APPs in triage and access, and kind of being that really the entry point for patients to the variety of services that can be delivered by the physicians and other professionals at Mayfield. So with that, whenever you're ready, please go ahead.
Well, hello, everyone. It's very nice to be here this morning, or this afternoon, I guess it almost is. So I want to talk to you a little bit today about the value of advanced practice providers. So just to give you a little bit of a background, advanced practice providers usually entails nurse practitioners or physician assistants. And we have both here at Mayfield. And we use them sort of in, very similar roles, but in different roles as well. But one of the things in a large outpatient neurosurgery practice is the patient experience. So we all should strive as providers in some way to exceed the expectation of the patient. And one way that I think is very intuitive to do that, and that we've incorporated here at Mayfield, is to try to touch that patient in every single way that we can, from that in a very unique and respectful way, from the first time the patient calls to the office visit. And another big thing about patient experience is making sure that we get those patients in and seen in a timely basis. You can go to the next slide, Tanya. So neurosurgery practices, particularly outpatient practices across the globe, are historically inundated with long appointment wait times. And long appointment wait times for patients usually leads to multiple different types of consequences. And one of the big things is patient satisfaction. And another big thing is that patients will often then seek emergency treatment in emergency rooms. So for a patient with radiculopathy or back pain, the emergency room really isn't the appropriate place for that patient to seek that treatment. So we needed to come up with a better way to get these patients in quickly, so that they're not contributing to higher healthcare costs, seeking treatment in places that it's really not appropriate. So for example, in this large Midwest neurosurgery outpatient practice that we have here in Cincinnati, and a few years ago, probably back in 2016, 2017, I looked at the data and I saw that it was taking about 3 to 4 months on average for a patient to get an appointment with a preferred provider within our organization. So again, the consequences of the waiting game for the patient are long appointment wait times. All of the data out there, all of the research shows that it leads to poor patient satisfaction. And the problem with poor patient satisfaction is that it ultimately leads to lower quality outcomes. And we are all reimbursed by outcomes these days. So we really need to pay attention to how we're serving these patients from the very beginning. One of the big things as well that contributes to the must-have of APPs in a neurosurgery practice is that the current ratio of surgeons to patients, or neurosurgery, and this comes directly from the AANS and the CNS, is about there's one neurosurgeon for every 61,000 patients. There are only 3,700 practicing neurosurgeons in the United States today. And there are 5,700 hospitals, okay? So there's a huge need and a shortage. And in fact, in 2017, the AANS and CNS released a position statement that said that neurosurgical care with the leadership of neurosurgeons should be team-based care, and that they should use what they refer to as mid-level providers, which are the same as advanced practice providers, so nurse practitioners and PAs. Not only is there a shortage in neurosurgery, the Association of American Medical Colleges predicts that there's going to be, this was published in 2021, an estimated shortage between 38,000 and 124,000 physicians by 2034. So that's going to be primarily in primary care, but also in specialty care. And this insufficient supply of specialty physicians, they're predicting that that deficit will actually be somewhere between 20 and 77,000. The surgical specialties, and this includes all surgical specialties, not just neurosurgery, is going to be somewhere between 16 and 30,000. And the physician, APRNs and PAs, that ratio to physician is actually going to decrease, meaning that physicians are going to go down and the supply of APRNs and PAs will grow faster than the physician supply will. This is just some data from the APRN, which is a nurse practitioner. That's where I am. So I have a lot of data about who we are and where we work. But this is the most recent data that came out in 2021. So there's going to be about 36,000 new nurse practitioners that completed their academic programs in 2019 and 2020. There are more than 325,000 licensed nurse practitioners in the United States today. They can prescribe. They hold a license in all 50 states. And then 81% of nurse practitioners can accept new Medicare patients. About 80% can accept new Medicaid patients. The majority, about 60% of NPs can see 3 or more patients per hour. So for example, I see about 4 patients per hour. And these are all new patients. So when you look at the physician shortage, the waiting game, and the supply of NPs and PAs outweighing the supply of physicians, what is the solution? Well, it really depends on who you ask. So back in 2016, as part of my doctorate project, I looked at our intake and how we were seeing patients. And I wanted to see if it was possible for a nurse practitioner to triage the patient in the same way that the surgeon would virtually using telehealth. So I had 2 nurse practitioners. We reviewed the same 100 patient cases in a test database during a month, while the surgeons simultaneously reviewed the same 2 surgeons actually simultaneously reviewed the same cases in the live database. That meaning that the surgeon's review was the one that was actually went through with the patient. We were just seeing if we could match what the patient, what the surgeon said on the background. So the results at the end of the day is that both nurse practitioners matched the surgeon diagnosis for the patient 100% of the time. During that review, we would make a recommendation as to an appointment type based on the patient's symptoms and whether or not there were any red flags present. So we would make a recommendation of whether the patient should be seen on a first available, an expedited, or an urgent appointment. So 95 to 100% of the time, the nurse practitioners and the surgeon matched the appointment recommendation at time frame. After we did the pilot research, we actually integrated an access program at Mayfield where we have two nurse practitioners now, one being myself, who work to triage the patients. And then we looked at that data at about 1.5 to 2 years post-implementation. In the first year, this data was collected in 2019. The Access Pod, or Access, I call it the Access Pod. The Access Pod launched in November of 2018. So in the first year, it was just myself. So I saw 858 new patients. 76% of those patients were seen within 7 calendar days. 40% were seen the same week that they called. And then it took about average days to the time that they called to their actual new patient visit, which was about 5.5 days. And during that first year as well, the average days to see a surgeon using the telehealth triage system was 62 days. As far as what type of patients did I see, 208 or 25% of them were sent to the surgeon directly for surgical consultation out of the 858. 92 or 44% of them actually went to surgery within the first 42 days, which was about how long it took to get an appointment with the surgeon. So you can imagine being that patient who has terrible sciatica or lumbar radiculopathy or whatever it may be, and they waited 42 days to see the surgeon, and these patients already went to surgery and had their problem corrected. 15% of the patients actually had same-day surgical consultations, meaning that they were seeing me in the office. The surgeon was there as well. And with the consultation with the surgeon, I was able to go find the surgeon and bring them in to meet with the patient, and the patient was consented for surgery that same day. When the patient did see the surgeon using the telehealth triage system, they're added about 2 to 4 months to their treatment timeline, meaning from the time they called to the time that they got to surgery. So this time, in this respect, we were able to cut down 2 to 4 months, a lot of times to within a few weeks. So what's the take-home message here? So if you look at the difference with the telehealth triage, where we have surgeons spending time outside of their very busy day, whether they're in surgery or seeing patients or taking care of everything else that they have to take care of, reviewing their cases and triaging patients. Usually would take about 2 months for the surgeon to actually see the patient after they reviewed it. And then the timeline from the first time the patient called to the final disposition of that patient, whether it being surgery or non-surgical care, was about 6 to 9 months for the patient. In the APP triage system, it took about 5 to 7 days for the initial appointment, from the time the patient called to the time they were seen. And then it took about 2 months from their initial phone call to surgery or final disposition. So you can see that we had a reduction of about 4 to 7 months of timeline. So the triage, this was a direct quote from one of the administrators at Mayfield about how the APP triage works. And so it was my feeling always that, and along with all of the great surgeons that I work with, that we want to be able to touch the patient. We want to be able to give the patient what they need and exceed their expectations. So this triage process with APPs was more sensitive to what the patient actually needed, because sometimes the patient just needed to know what was wrong with them because they were scared or they were worried or whatever it may be. So when that patient felt that they had a real need, or if they did really have a need to be seen, the nurse practitioners could expedite that in a way that the telehealth triage system or the PC system could not. So the averages don't really tell the whole story from a patient experience standpoint. So we have multiple locations within Cincinnati, which I'm sure you've heard throughout this presentation, but I'm the lead NP in our Rookwood office. I also now see patients in our Anderson office, which we opened. And then we have APPs in our Kentucky office, Green Township office, as well as our Westchester office. What do we see in the APP Access Pod? We mostly see all new patients. So that's the goal, is to get these new patients in the door, triage them to a path of a surgical path or a non-surgical path. So getting their non-surgical treatment done first so that they can then see the surgeon and have surgery, or they really just don't have a surgical problem at all, and they need to just completely go on the non-surgical path. We see a lot of acute back pain, which means less than 6 weeks. They don't have any red flags, or they haven't had any imaging when they call. So they come in and see us. Most insurance companies will require for acute back pain or radiculopathy without deficit today about 4 to 6 weeks of physical therapy before they will approve any type of advanced imaging for these patients. What is the patient's preference, right? Or maybe the patient's not interested in surgery. I can't tell you how many times over the last 20 years that I've worked in neurosurgery that you would see it when I worked directly with the surgeon, would see their patients in the office. The patient would come in and be like, I don't want surgery. So that really helps the surgeons as well to keep the surgical patients on their schedule instead of the non-surgical patients. The patients who remain in what we call priority consult, those are the patients that just prefer that remote process. They don't want to come in. They don't have time. Or they're only interested in a surgeon visit. They don't want to meet with a nurse practitioner. Or they have a more chronic problem or a more complex problem. For example, our complex spine patients who have had multiple surgeries or need a scoliotic deformity type surgery. Those patients are really more appropriate for our neurosurgeons. So it's a win-win for everyone, right? So nurse practitioners are very valuable. They are very valuable to every neurosurgery practice. They're valuable to all different types of specialty practice, but particularly in neurosurgery. They make sure that the patients are seen efficiently, effectively. Nurse practitioners, if you look at all the literatures, they have very high quality outcomes, good patient satisfaction scores. We're nurses first, so we tend to spend a lot of time with the patients. We're qualified, trained well when we're trained by the best to take care of patients, recognize red flags, and get the patients to where they need to be first. So nurse practitioners and any neurosurgery practice, in my utmost opinion, are a must-have for a successful neurosurgical practice. Next slide, Tanya. Oh, that's it.
Great. So I think with that, maybe we'll hold questions and we'll, for the panel at the end. But thank you for that really impressive talk. Looking at some of the magnitude of the differences between the APP triage and the telehealth triage, the scientist in me was just thinking those p-values had to be really, really low. So that's awesome. That's they
were very significant.
No, that's great. So let me go ahead and bring Mayfield on. Perfect. All righty. Okay, so now that you heard the APP perspective on the spine-focused care, we're going to move on to the spine-focused physical therapy model. And we're joined by Lisa Cleveland, who is the director of physical therapy at the Mayfield Clinic. And she's going to talk about the role and the value of physical therapy and a spine-focused physical therapy model in the management of our neurosurgical spine patients. So thanks, Lisa, for joining us.
Great. Thanks for having me. Appreciate it. So just going to talk a little bit about what physical therapy is like at Mayfield. We are definitely more manually based and focused on the spine, unlike any other sports medicine clinic. We're not a no pain, no gain clinic. We're very protocol driven with the surgeons. And right now I have 30 physical therapists at Mayfield. There are 16 PTs, 14 physical therapy assistants, and we are located at all 5 locations at Mayfield. So what sets us apart? I think a little bit more continuing education. We're always looking for that next new thing to do, as far as we do a lot of things like dry needling and cupping. We have a really great relationship with the docs, the PM&Rs, and the APPs here. So if there is something that's going on with a patient, we can walk right across the hall and say, hey, we're finding some myelopathic symptoms. We're finding some bowel and bladder changes. Can we get the patient over to see you right away? So we're a great second look at patients, or if they come in through our priority consult, they may come to us first, even before maybe they have some testing, and we can kind of evaluate them and then get them right back to the docs if that's where we feel that they need to go. Also, having access to the medical records and testing such as the MRIs, the CT scans, things like that, I think we're a definite second education team for the patient. So we can look at their MRIs with them and kind of go through with them why we're doing what we're doing, why we're doing the exercises we're doing, what our goals are. And I think there's a little bit better buy-in from the patient, knowing A, we're seeing the exact same thing the surgeon's seeing, and B, we can go right over across the hall and talk to them if we need to. Having access at the surgery center is a bonus. That way we know what's happening from a surgical perspective. We know what the surgical outcome is going to look like. And we also know tissue damage, which gives us a much better outcome, and kind of looking at our protocols, much better way of looking at what we're doing. Services we offer, it's kind of the typical physical therapy is the things you see listed. As I stated, we are big into the dry needling and cupping. But the other thing we found that we can offer at Mayfield is programs that are very specific to our surgeons. So we've started things like preoperative programs for anybody who's going to go through a normal pressure hydrocephalus, and then we can assess them post. We've done some DBS programming. We've done some spinal cord stim research projects with the docs. And we've also do pre-op testing for our SI patients, just to let them know what they need and any kind of assistive devices moving forward. SI being the sacroiliac joint. Bracing, we also brought bracing in-house with our physical therapists because we figured who better to fit the patient and know how to teach them to wear the brace. So we go through with them donning and doffing, what their wear time is going to be, how often they're going to be in it, what their typical surgeon's protocol is. And the other thing we can do is, because let's say someone's having a 3 or 4 level cervical fusion, we may need to make some adjustments post-surgery. So a lot of times we tell them, come back, let us make adjustments. We also find that sometimes people touch them in the hospitals that shouldn't. And so we like to bring them back and do a little assessment and maybe review their wear patterns with them. In physical therapy, we also teach the spine fusion class, and this is something we offer right now. We were offering it monthly prior to COVID. Right now, we're offering it every other month, and we get a really good turnout for this. I think it's a lot of patients who have questions in regards to, first of all, what am I expecting and what is he going to be doing when he's in there? He or she, I should say. Also, what can I do to adapt my home? We talked to them about picking up carpets and, not having throat rugs. And what are you going to do with your pet? Because now you're coming home with a big surgeon or, a big surgery. So we can review all those ADLs with them. We get a lot of questions about the braces, support at home, navigation after surgery. We also have our nurse navigators present at the spine fusion classes. And then that way, if they have questions in regard to medications, or am I going to go to a nursing home? Am I going to go to a rehab facility? We can cover all those things. We also go through the basics of how am I going to get in and out of my car? How am I going to get in and out of bed? I'm wearing this brace. How is this going to work? So there's a lot of do's and don'ts we cover at our spine fusion class. Enhanced recovery after spine surgery. This has obviously been a big buzz the last probably 10 years or so. And I think this is another area where physical therapy can be valuable in the education area. We try to spend time with these guys, whether it's before surgery or in the spine fusion class, talking to them about how to best practice for getting ready for their surgery. Obviously, smoking is a big one. We talk about bone health, and that just leads to the whole nutrition thing. Having better control of their blood sugar. The frailty is, just at least if we can get them on a walking program or get them doing some type of exercise and getting those muscles stimulated before surgery. And then obviously we also cover their bracing and some bone stimulator information. Post-op physical therapy, we started this program at Mayfield probably about 6-7 years ago. And what we do is we go in and see the patients even before the doctor does at their 2-week follow-up. These are the things that we review with them, like their reflexes, their strength and balance. We go through the lifting restrictions. We initiate a little bit of a home exercise program, not a lot at 2 weeks. And like if they're a 1 or 2 level program, or level 1 or 2 level fusion, we'll start a little bit of a program. If they're a complex case, we're probably holding them off a little bit longer. Go through their do's and don'ts. We do an incision check for any kind of stitches or staples. And then typically we will start them in formal physical therapy at week 3. Our surgeons, on the other hand, will see them at that 2, 6, and 12-week postoperatively. So at the 2-week visit, once we're through with the things that we have listed, the physician will come in and we'll go through medications with them and anything else. But what we're trying to do with this program is take the educational piece off the surgeon's hands so they're not having to spend so much time in the room. That way we've covered it, we've gone through their ADLs, and they can come in, do a quick visit, boom, get back out again. As far as the Mayfield network, we have a lot of providers in the area that we share protocols with because we know we're kind of a different facility and we need everybody to be on the same page. We find this especially with our Chiari patients, our complex spines, and our arthroplasties. A lot of physical therapists aren't used to dealing with those diagnoses. So we like to make sure that we do have a good resource for everyone and where we can send them. We found that we get more and more from the outside the greater Cincinnati area. And just because we are a Mayfield practice, and I am a physician-owned practice, this is also a Stark requirement. And that's kind of physical therapy in a nutshell.
Great, thank you. It's always so interesting to hear from physical therapy because there's so much to the patient's care that I think is outside of the realm of what we see as medical students and training physicians, and a lot of that is taken care of by physical therapy in order to get them back to a functional state. So now to move on to the next area of allied neurosurgical care. We're going to hear from Dr. Linda Groh, one of the interventional pain management specialists at Mayfield. Dr. Groh completed her undergraduate studies at Duke University, medical school at The Ohio State University. And I made sure to say The Ohio State, not Ohio State. And then went on to do residency and fellowship in anesthesia and pain management, respectively, at the University of Cincinnati. So Dr. Groh, thanks for joining us to share a little bit about the non-surgical management of pain.
Oh, you're welcome. I'm happy to be here. So interventional pain is a kind of an adjunct. It's an important adjunct for a lot of reasons. A, because a lot of people don't want to have surgery, at least as their initial care. And unfortunately, maybe more importantly, B, because the insurance companies require it. We have a large PM&R interventional pain team at the various locations for Rookwood. We have physicians, we have PAs, nurse practitioners, x-ray techs that help in our procedures. We have MAs and medical secretaries and a wide variety of people that all make up this team that we work with. So we, the physiatrists specifically are kind of a bridge between the surgeons and the physical therapists. They help with, kind of guide the therapy and things with bracing. They also do, some of the physiatrists do interventional pain, some do not. And we have 2 of each here at Mayfield. And we then go into the different interventional type procedures. We do a full diagnostic workup. It's focused history, physical examination. You can often tell a lot by what you see in the physical. The imaging is helpful. Imaging is not the end all be all, because if you, as I tell patients all the time, if we injected them based on an MRI scan, we'd be in the wrong place a lot of times. So we really need to examine the patient and talk to the patient and listen to what they're saying. We order additional imaging if we need it, although most of the time there's a lot of imaging there and other studies like EMGs available already. So we, a lot of times the patients have already seen a nurse practitioner or a PA or one of the surgeons, and we are not the first line person. On occasion we are, and we are ordering, but that's not the typical norm. So treatment options, we have basic medications, and again, by the time the patients get to us, most of them have been on anti-inflammatories, muscle relaxants, various pain medications, oral steroids, the topicals, patches, you name it, they've tried it typically. It's kind of plus minus whether they've done physical therapy or not, and in today's world, insurance makes a lot of them do physical therapy before they can have injections, which is a little ridiculous in my mind because they can't really do the therapy. So you can't benefit from therapy if you can't do it, if you're hurting too bad. So it's kind of backwards. But unfortunately, that's the world we live in. But once we get through those hurdles, we look at what injections are appropriate for them. We can do epidural injections. We can do injections focused on the joints, either the sacroiliac or facet joints. The physiatrist will sometimes do hip or knee joint injections if needed. We will do the nerve blocks for the facet joint, which is the MBB, which is medial branch blocks. Those are diagnostic blocks that are for the facet joint. And then the radiofrequency ablation is focused on the facet joint that will give more longer-term relief. The SI joint radiofrequency ablation is a really good tool, but unfortunately, insurance has taken that away from us as of March 19th. So that is no longer a covered service with almost any insurance that we deal with. The spinal cord stimulation is kind of a last resort. It's for people who either can't have surgery, have had surgery and still have issues, or just are old enough that they don't want a big fusion or something like that. So there's a variety of patients that can fit in that box. And some of the insurances are easy to get that passed, and some of them it's a lot of back and forth with the insurance company, and some of them we know from the get-go we will never get it approved. So injections overall are both diagnostic and therapeutic, almost all of them, because most of them use local. So we use small amounts of local, and if you put a small amount of local in a joint near a nerve, and that makes the patient feel better for a number of hours, that is, diagnostic that joint or that nerve is the issue. If we think it is, we do an injection at the C5 nerve and put a little bit of local there and they don't get better, then C5 is probably not the problem if we have a good picture and outline of that nerve. The therapeutic part is the steroid, and it reduces inflammation, swelling, all the things that steroid does very locally in that area, and allows, the other, nice mediators that heal things to come in and do their job, because they won't work very well when those inflammatory mediators are all revved up in that area. And it also helps, allow the patient to have a reduction in pain, participate in physical therapy, return to their normal activities, things like that. And epidurals, they're useful depending on how long they last, and that's something we have no way of predicting. So we do them. We hope the patient gets long-term relief. If they don't, we look at other options for them, surgery or, different injections, different levels, the stimulators, things like that. But they don't, unfortunately, help everybody. So epidural injections, there are two approaches. One is foraminal, coming in as out the, next to the nerve root as it's exiting the foramen. And both are good options. The interlaminar approach is more what you think of when you think of a labor epidural, where you're kind of more midline and you go between the spinous processes. And both of these types of epidurals, depending on whose study you read, some say one is better, some say the other is better. There's not been one that's definitively said one is better than the other. And some patients respond to one, some patients respond to another. It really just depends on the patient. And again, that's one of those things, there's really not a way to predict. You think you can say foraminal disc herniation, they need a foraminal. Not everybody with a foraminal disc herniation will do as well with a foraminal epidural as they will with an interlaminar epidural. So it's one of those, you just got to try it and figure it out, unfortunately. The SI joint injections are for people who have more lumbosacral, sometimes buttocks, hip, proximal leg pain. We see this a lot after fusion. There tend to be a lot of SI joint dysfunction post-fusion. And these are pretty simple. They're about a 2-minute procedure. You open the, kind of angle your C-arm, open the joint, get a needle into that joint, and image it with a little bit of contrast, then Novocaine is steroid in the joint. Again, the Novocaine is a diagnostic part, steroid is the treatment part, and there's a gap between them. So it's pretty easy for patients to tell if they're better for a couple hours, then, that's a great sign that diagnostically that joint is the issue. Then we need to wait over a few days and see what the steroid does, because steroid typically is a 2, 3, 4, 5, day kind of onset. In the past, we could do the radiofrequency ablation of the lateral branches that come out of the sacral foramina. But unfortunately, again, insurance rules the world, and that is not an option, even though it is a very good and useful and helpful treatment for patients. And I do actually have a few people who were in the process when they changed their Medicare guidelines on March 19th, and these people are choosing to pay out of pocket for it. So the diagnostic blocks for the facet joints, whether you're lumbar or cervical, are these medial branches, where the medial branch kind of drapes over the transverse process. If you can kind of picture it here, and we put a small amount, just a 0.5 milliliter of local if you're in the lumbar, and 1/4 milliliter if you're in the cervical, right in position along that nerve. We tell the patients to go do things that bother them, and they report back the next day and give us a report of 0 is not better, 100% is perfect. How good do you feel? And we want them actually doing activities that they typically hate. So if over, 5, 6, 8 hours, they feel amazing, then because of insurance, again, we have to repeat the blocks again, and have a second good diagnostic block, and then we can proceed to the radiofrequency ablation. We do not do the medial branch blocks in the thoracic spine, not because they don't work, but because insurance won't pay for them. So that is a no-go, unfortunately. The radiofrequency ablation, needles placed in the same position. There are some steps we have to go through, so it's not a more painful procedure, it's a more tedious procedure. And we put the needle in position, put electrode through it. We do some sensory stimulation, so patients feel a very, very faint little tingle, buzz, pressure, vibration. When we're within a certain voltage range, we know we're pretty much on top of the nerve. The difference between the test and the ablation is that during the test, if I'm near the nerve, the local's liquid, it's going to get there. If I'm doing an ablation, if I'm burning the nerve, I want to be as smack dab on top of that thing as I can. So we find the nerve, and then we do a second test. As you can see, the nerve roots are kind of right anterior to where we are. So we want to make sure we're not close to them. Usually by your imaging, you're 99% sure you're nowhere near them, but the second test causes some kind of twitching and thumping of the muscles in the back, the hip and the buttock, as long as there's no movement or twitching or anything in the leg. So once that's done, Novocaine there, wait and give it time to work, and then the ablation part. Most practitioners are putting a little bit of steroid in after the ablation. It just helps it work a lot faster. So they get a little bit kind of quick relief. They get the Novocaine and then the steroid, and then the ablation kicks in. Without steroid, it would be anywhere from 2 weeks, 4 weeks, maybe 6 weeks, because it's a Wallerian degeneration type thing. So spinal cord stimulation. So this is placed to stimulate the dorsal column, and we put it in through an epidural needle. Again, very similar to a labor needle. You thread it up like you thread up a labor epidural, like an OB. Typically for low back, we are sitting T7, T8, T9. For cervical, it's kind of all over the place. If we're trying to get neck and arm pain, it's one of those, you don't know exactly what level you'll sit, maybe C4 or C5, something like that. Once the temporary one is thread in through the needle, on the table, we do a test for the patient. So the test, we send a little tingly kind of sensation through the electrode. It's kind of like a TENS unit, if anybody's ever had or used one of those. It makes this tingle feeling, and we want the patient to feel tingle everywhere that they typically hurt. And once we get that good position, it's taped in place sterilely. People keep it for 4, 5, 6, 7 days and go home and do things. The caveat is you can't bend and lift too much, because you will pull that out of position and then it just won't work. Doesn't hurt anything, but just doesn't work. And secondly, that they can't be doing activities that are dirty, because this is just taped in place. It's a catheter coming out of their spine, taped in place with, covered sterilely, but we don't want them digging in dirt, being in the, in the garage, in the basement, those kind of things. And, some guy went under this, tried to work under his car. Those are no-nos. So yeah, don't want them dirty. And then if they have a good trial, which insurance wants them to have 80% improvement, and that can be pain, function, or a combination of both, it could even be sleep. Then we go on to the permanent, which is placed by the surgeons, and they do a small incision in the spine. In that same area, we send the imaging over so that they know exactly where the trial leads were placed, so they know where to place the leads for the permanent. And then there's a small incision for the generator that's just it's basically like a pacemaker type thing. So if you think of it, it's kind of a pacemaker for the back if you want to make it very, very simple for your brain. And most people do well with these. If you have good patient selection, I think at this point, my trial to getting an implant ratio is somewhere around 90. It kind of goes between 87 and about 94. So that's pretty high if you look at the national average. And it's all about patient selection and preparing the patients and, really letting them know what reality is, not sugarcoating it, things like that. And there's a lot of other injections that we do. And we try to work with the surgeons. If somebody's asking me for an injection at L4-5 and they say, let's do a foraminal at L4-5, which gets you the L4 route, but the L5 route's the one being, impinged, then I'll send them a note back and say, hey, do you want me to do both the L4 and the L5, or, what are you looking for? So we'll try to make sure that when the patient comes that they're getting the injection that has the most chance of, giving them benefit. A lot of times, when you're not the person who has the needle in your hand, those are like little nuances. You don't really think about them because you don't do them. So that's all I have.
Great. Thank you. Yeah, always a little disheartening to hear about the insurance world and how that influences practice. But thank you for, keeping it real.
Yeah.
All right. So Dr. Tobler is going to join us again to kind of conclude the didactic portion of this, talking about outpatient versus inpatient spine surgery care in the outpatient surgery center at Mayfield. And then we'll move into our panel discussion. So Dr. Tobler, take us away.
Thank you. So you saw this slide earlier in the presentation. The Mayfield Spine Surgery Center and its development and implementation was a game changer for the surgeons involved. It is a trend that is around the country. I think that we were one of the leaders and one of the innovators who created this on a little bit larger scale. There are many small outpatient surgery centers that are owned and operated by one or two or three physician groups, but we've done this on a larger scale. We do approximately 1,500 surgeries a year. We do around 7,000 or 8,000 pain procedures, and I'm not going to reiterate what we already discussed, but we do have advanced technology in our outpatient surgery center. What you see there in the middle of the bottom row of pictures is an O-arm. It is it's an X-ray machine that creates, by way of software, a CT scan-like picture of the spine. And this is very helpful for the procedures where we place implants in the spine. So a summary of our experience over a 15-year period of time is that we've treated almost 90,000 patients and probably have reached that number now since this slide was created. 70,000 pain procedures, a total of 20,000 surgical cases with a high degree of satisfaction. And as I alluded to before, the costs that are submitted to the insurance company, for example, United Healthcare is one of the big insurance companies in this country. The bill that is submitted from the surgery center is generally about 50% of the bill that's submitted to the insurance company for the exact same procedure. So there is a reduction in the cost to the healthcare system in a global way with outpatient surgery. And I think that the Center for Health and Human Services, which covers Medicare and Medicaid programs, is all in favor of encouraging the proliferation and growth of outpatient surgery centers. This is a problem for hospital systems because this this results in the hospital losing cases and losing the income associated with it. This is part of the economic equation that is not discussed in medical school education. And unfortunately, it is how the real world works. In the ideal world, we would treat patients with whatever procedure we have without giving any regard to cost. But that's not how the real world works. I mean, we have to pay for the employees. We have to pay for the facilities. We have to have an economic model that is solvent in order to produce and provide the services that we do. And this might be considered the underbelly of medicine to talk about money or finances, but it's very real. And it is what every single medical student will eventually have to confront and work with in order to be productive in the delivery of healthcare. So with regard to our own patient satisfaction, we have a staff of about 74 employees who take care of the patients from start to finish. For example, if you come into the outpatient surgery center for an operation, you walk in the facility an hour beforehand. You're greeted by a nurse who will get you ready for the surgery. That's the first person that you will see when you wake up from the surgery, and that nurse will walk you out to your car. In a typical hospital setting, you will walk into the hospital and be told to get there 2 hours ahead of time. You will be escorted to sign in. Then you'll be taken to a pre-op holding area. Then you'll be put on a cart and sent to the operating room. That might be a little bit of a ride. And then when you wake up, you go to a recovery room that is yet another different place. And then when you finish being immediately cared for after anesthesia in the recovery room, then you're transported to yet another place, and it's not the same place where you were transported to when you came into the hospital. So maybe some of you listening to this may have a personal experience with that. But the fact is, in the outpatient surgery center, it's much more efficient, it's much more friendly. You have the same people taking care of you pre and post-op. And I always tell people that having surgery in a good outpatient center is very like flying on a private jet rather than flying on some big commercial airline where you're back in steerage with the rest of the cattle. So anyway, this is what is rewarding for the physicians because we hear about it from our patients. The patients love the experience they had at the surgery center. They would do it again and again and again. And we deliver the topmost quality of care. There's a value proposition for the surgeons who are involved in putting together, designing, and executing an outpatient surgery center. The physicians are much more included in the process. Physicians are not included at the high levels of development in hospitals. This facility was designed by the surgeons. The equipment is chosen by the surgeons. And we are efficient because we have experienced employees who do it over and over and over again. We limit the numbers of operations that we perform so that we're not trying to deal with one of 20 or 30 different kinds of procedures with completely different instrument trays and all of the equipment that is required in delivery of multi-specialty care in a surgery center or in a hospital. And as I noted again, the cost is much less. And as a result of all of these features, there's a growing trend toward outpatient surgery. So the surgeons also are very instrumental in deciding, well, what patients do you take to the outpatient surgery center? Well, in spine, there's 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. So there's a lot of vertebrae. And in complex surgery, we're often dealing with 7 or 8 or 10 or 12 levels. And that's a big, big surgery. The higher proportion of cases are surgeries like you see here, where you might deal with 1 or 2 levels, occasionally 3 levels. So that is a surgery that's more limited in scope, limited in the incisions that are made, limited in the blood loss, and limited in the time under anesthesia. So these are all the procedures that are easily facilitated in the surgery centers, procedures which can be accomplished in under 2 hours and in which patients can be able to go home within a 24-hour period. Many of these more complex surgeries require patients to be in the hospital for extended periods of time. So the type of surgery is one determinant. The other is the patient's condition. So all patients are not the same. Some patients have very significant medical comorbidities, such as unstable angina, congestive heart failure, obesity, brittle diabetes, and many other things like this, including certain levels of obesity. So there are certain patient comorbidities that are based upon the surgeon's judgment, but also the surgeon makes this, completes a discussion with the anesthesiologists who work at the center to sometimes say, we have a simple operation here, but this patient needs to be done in the hospital setting. There are a lot of surgeries that can be done that do not require general anesthesia. So these are insertion of pain pumps, peripheral nerve surgery, like carpal tunnel syndrome and things like that are easily done in the outpatient setting. So after treating thousands of patients, we have a pretty good idea. And that process is not, that determination is not a laborious process in most cases. So what we've learned in 15 years is a plus, a win-win-win for every stakeholder involved in the delivery of surgical care for spine disease. The surgery is safe in the outpatient setting. It's physician controlled, efficient, high satisfaction rating. Physicians are happier because we can do more cases in a day, because efficiency is one of the hallmarks of the surgery center. The worst thing, and medical students might not realize this, but there are a lot of bad terms in life in the practice of medicine. One is overhead, which is the cost of running your practice. But in operating room parlance, turnover time. In other words, if you're doing 3 operations, how long does it take from the moment the patient is wheeled out of the operating room, finishing the surgery, to when you can start the second surgery? In the hospital, turnover time can be 45 minutes to an hour, sometimes even longer. In the outpatient surgery setting, for the same operation, turnover time is about 12 minutes. Surgeons have limited hours in the day, and one of the worst moments to waste time that drives physicians, surgeons crazy, is prolonged turnover times. Anyway, those are things that medical students don't think about, but they become very, very important once you reach the completion of your training and you're in practice of one form or another. So I think that that's the end of the formal presentation. We have some time to answer any questions, including Dr. Ringer is working, as he told you. But I can certainly answer questions concerning any of the topics today, as well as Dr. Grove and Lisa Cleveland. Thank you very much.
Yeah, thank you all for a really great panel of discussions on the various aspects of interdisciplinary neurosurgical care, and again, the business and the economics that, like you said, we don't often think about as medical students or even into later stages of training. So this is a great time for folks on the net to put your questions in the chat for any of these folks. Just to kind of kick one off, I think during training we often are siloed and we're not really thinking so much about what the type of training our colleagues are receiving. So we heard a little bit about the neurosurgical pathway, but maybe we can hear about the training for physical therapy and then for interventional pain management and what those kind of compare.
Okay, Lisa?
Yeah, absolutely. So right now, a physical therapy degree is a 7-year. It is a doctorate program. When I came out 35 years ago, it was a 5-year program, and then it went to a master's degree, and now it is a doctorate program. Our physical therapy assistants basically have they have an associate's degree, but most of them have also a bachelor's degree to go with it. And a lot of my physical therapy assistants are also athletic trainer trained. So it kind of makes it nice because they have a much better understanding of the anatomy. So I feel like they get a little more that way.
Sure.
Well, thank you, Dr. Cleveland.
I am not.
Dr. Crow?
Interventional pain, it can come out of a lot of different disciplines. You do an anesthesia residency, you can do a neurology residency, physical medicine rehab, and some radiology. And then you do a fellowship. So it's whatever your residency is. So, 4 or 5 years. And then most fellowships are a year. The nice thing about coming out of an anesthesia program is that from day one, we are, just to be blunt, sticking needles in people. You start going to OB in the middle of the night and doing epidurals without any kind of imaging, and you learn very quickly to be good with a needle in your hand or you're in the wrong specialty. So, so that's, and if you like procedures there, with anesthesia now, there is a, with all the perioperative blocks that we do, there are actually acute pain fellowships that do the perioperative blocks that are different than the chronic interventional pain. And most pain fellowships do the interventional part of things, at least in anesthesia, but we also do medication management, therapy, multidisciplinary. And that's another thing that insurance took away, because multidisciplinary pain management, where patients who are chronic pain patients go through a intensive 4-week program with PT, OT, psychology, medications and blocks and things, really does work, but it's expensive. And so, even if it works, nobody wants to pay for it. So does that give you what you want?
Definitely. Dr. Tobler, maybe you can highlight or, collectively what the training for an APP looks like, because I don't think Jody is back on the web.
Well, I think it requires an undergraduate degree, and that can be really in any discipline. But then there's graduate studies. Yeah, you have to get a master's degree. Yeah, which is at least a minimum of 2 years. And then I don't think that the doctorate aspect of it is totally required. So I think most of the APPs and NPs have about 4 to 6 years of university and graduate degree.
Them, whether you're a PA or an NP, it's your undergrad, and then you go to a 2-year master's. Mm-hmm.
Sure. And then is there, and in physical therapy as well, is there kind of postgraduate or residency type training? Is that becoming more common?
There are residencies, and they're mainly specialized either in a manual residency, which some of my staff are actually leaning towards, and then they do have one in orthopedics. There isn't one in neurosurgery right now. So
not yet, at least. Maybe.
Not yet. Yeah.
And they might have to change that term, manual.
I know.
Lisa's not that good.
No, she can do that. Exactly.
Personal.
Exactly.
Let's. So again, any folks on the net would like to have questions for our panel here, please put them into the chat. So you all, were able to speak on, some of the business and the economics of neurosurgery, and this was a question that I posed a little bit to Dr. Ringer. But how did you all get, aside from the hands-on or on the job training in this area, how did you become versed in some of these topics that we talked about today?
Yeah, I'll start. I can tell you when I first came to Mayfield, first of all, there are not a lot of neurosurgical practices that have physical therapy. So I was calling around the country and looking for protocols and ways to do things, just because there aren't physical therapy protocols for specifically the back and neck and postoperatively. So that was a real challenge for me. Dr. Tobler did one of the first SI fusions here in town. And I came to him and I said, okay, we got to now come up with a protocol, right? Because there wasn't one. And just kind of went through the mechanics and what made sense to us, and kind of have started designing our own protocols based on what we know and our knowledge of, healing time and surgical procedures and things like that. But there's still a lot missing there in the neurosurgical world as far as physical therapy goes, I think.
Sure.
And I think something that Lisa, I kind of heard her touching on with the pre-op preparation, that all ties in with this whole peri-op surgical home concept. And it really does impact everybody in the hospital. And it really impacts the surgeons, because if patients are well prepared, the cancellation rate goes down markedly. And the last thing the surgeon wants is their anesthesiologist to come to them and say, well, we're canceling because, and most of the time, especially if you have a good relationship with your surgeon, they will understand why you're doing it, but they're never going to be happy about it.
Sure.
So that whole pre-op preparation, it doesn't matter whether it's neurosurgery or whatever surgery it is critical to make the system flow and flow well. And it's really important economically. So.
I also think one other point that I wanted to make when I was talking about the physical therapy department, and Dr. Groh did touch on this, the insurance companies are pushing for physical therapy first, correct? So we are even finding ourselves in the position where we're failing a patient in physical therapy, so I can get him to Dr. Tobler quicker, and then he can do the surgery. So having us here so that they don't get lost in a system somewhere else and having to go to physical therapy before you get them back is also a benefit, I think, since we're right here on site.
Well, unfortunately, one of the underlying themes of the discussion is another part of the underbelly of medicine is the control that the insurance companies have. And I would look at the entire perspective of healthcare that at least I've been exposed to going back into as long ago as the 1970s, is that right now we're in a bad place, because the autonomy of physicians and healthcare providers is being directed by other sources, and these are distant sources. These are people that are in another city. They're in an office building. Many of them have never even been in an exam room with a patient for one moment. And this is a really, really bad time that we're in, where the autonomy has been taken away from the healthcare providers who are in the trenches. And what's good for one patient is not good for all. And that the insurance companies are trying to mandate that what's good for one patient is good for all. And honestly, it's done with lip service to providing better care or to saving money. And many of these requirements are redundant and wasteful of resources. Mandating 6 weeks of physical therapy before somebody can get an MRI is insane, because it's not saving money, it's costing more money. And
it's like the SIRF.
Everybody should be in a position to have some autonomy with regard to independent decisions, and with regard to the best interest of everybody involved, and that's efficient, cost-effective care. It's bad right now.
Great.
Yeah. I think maybe that's one thing in medical school we do hear about the challenges of insurance. And there's big pushes towards. I think in a lot of ways people talk about giving more control in some ways with single payer or solutions like that. Are there any innovative policies or solutions that you feel would improve the system?
Well, we're getting off into a discussion that could be another webinar.
Another 3 hours.
But the bottom line is, no matter what model you enter, whether it's an academic model, a hospital employed model, or a private practice model, these pressures and the need to deal with insurance companies is everywhere. Doesn't matter what practice model you're in.
Yeah, I always joke with patients that the reason I went to med school was to work on a computer and fight with insurance companies. That was my reason. So that's kind of what we do a lot of.
Yeah. And as disheartening as it is to hear, I think it's important, for medical students, and even we do get undergraduates that join the webinars and are considering a career in medicine. And I don't think it should be discouraging, but it should be realistic that they recognize what the healthcare environment is like. Right
I'll just provide an anecdote that kind of sums it up a little bit, and then we can end it. I'm sitting in my office. I see a patient. And that patient has a clear-cut problem and needs an MRI. It used to be that we could order the MRI and then behind the scenes, then figure out how to pay for it, right? Either the patient has insurance or maybe doesn't have insurance or whatever. But now what happens now is about a few days later, one of my assistant comes up and gives me a piece of paper that's a Xerox copy of a document from the insurance company that says I have to have what's called a peer-to-peer conference call with somebody. So I have to make a telephone call. I have to wait to get that person on the line. And a lot of times a secretary or somebody answers and says, okay, I'll get Dr. So-and-so. And then you wait again, and then Dr. So-and-so comes on, and the word peer needs to be recognized. And I'm talking to this doctor. He says, well, why do you need an MRI? And well, I say, who are you? Well, I'm a family doctor. And I'm like, you don't have a level of, and I'm not disparaging a family doctor, but they do something different and they have a different expertise. But we have to go through this process. I mean, we see 10,000 patients a year. Those 10,000 patients get another 25,000 procedures. And we keep getting cut back on the amount of reimbursement the corporation or the clinic gets for the 15 minutes that we see the patient. And then we have to spend another 15 minutes begging to get an MRI scan that may or may not be granted. And we get no reimbursement for that time. That time adds up day after day. And this is another very, very bad part of the practice of medicine.
Yeah, and it adds to those administrative costs, that you were talking about earlier. Well, I don't want to end on a negative note. Talking about the challenges of medicine. Because this is all revolving around collaborative interdisciplinary care. Maybe you guys could share a story where that interdisciplinary care really worked for a patient. And I'm sure there are many that you can think of, but if anybody stands out in your mind.
Well, without violating HIPAA policies and so forth, we really can't talk too much about things other than in generalities. But underlying all this is you have to first proceed through your medical education with the goal of finding your passion in life. And once you find your passion in life and pursue it, a lot of these aggravations fall by the wayside, or they're manageable. And I think that all of us here at this table are passionate about what we do. I'm not, after all these years, personally, I'm not bored with it. I'm aggravated by these things I've talked about. But at the end of the day, we change lives. And you sit in a room with a patient, just the two of you, or with the patient and their spouse, and they look at you in the eye and say, "You changed my life." I mean, that is a very, very powerful incentive and reward, because money's important. It's nice to make a big paycheck. There's a lot of people making big paychecks in other fields, but they don't have that interaction where somebody actually looks them in the eyes and say, "You saved my life." And that's not just that's a truth. It's not just a cliche. Because I feel like I've seen situations where doctors have saved and preserved the life of myself or my family members. And so being a physician and being on the other side of that also helps bring that lesson home. But you can't get that in many other professions.
And I think you have to realize you want to work in medicine, and unfortunately you end up having to work in healthcare, and they are two different things. So
Yeah, that's a really great way to put it. The medical practice is the beauty of healthcare.
Practicing medicine is amazing. Working in healthcare is not necessarily always amazing.
Well, on that note, I think that is a great way to sum this up. Thank you all for taking the time. And I don't know if Tanya is there in the background somewhere, but I really want to highlight all the work that she did in helping to organize this. The slides were incredible. I know she was, really the lead behind putting those together. And same to, is Deb there as well?
Agree completely.
Yes, Deb is here as well.
Agree completely.
Yeah, thank you. There they are.
Get your head in, Tanya.
Having somebody.
Yeah, get a head in there.
It is.
Definitely would not have been possible without all their support. And we here at Brain and Spine Group and the Neurosurgery Training Center are incredibly grateful to you all for the continued support of our educational programming.
Right, thank you very much. Thank you.
All right, folks, take care and have a good rest of your Saturday.
Great day.